Jai Shri Ram, pranam.
Anji, hi, Indrani. We seem to be meeting every week. Good. I'm happy.
Dr. Ekadash, it's 6 o'clock. We can start.
Yes, sir.
Naveen sir,
Jai Shri
namaste.
Madam, good evening.
Yeah.
Good evening, Naveen sir. Good evening.
Can we start now?
I think we can start. We should start.
Okay. A very good evening to all the esteemed members and senior members of RSCCP. Our President, Dr. Sharma sir, our ever dynamic Secretary, Dr. Naveen Malhotra sir, and our ever inspiring patrons, Dr. Tejkal sir, is he there? I have not seen him yet. And Dr. Avtar sir, we are still waiting for them to come over. Our President-elect, Dr. Indrani Madam, Vice President, Dr. Sarvari Madam, and our other senior EC members of RSCCP, and all other senior and esteemed members present here. Today, our theme is anesthesia and laparoscopy. So our first speaker is Dr. Jayashree Sood Madam. She will be speaking on anesthetic challenges in robotic-assisted urological surgery. And this session will be chaired by none other than Professor Nivedita Pani, who is the HOD of the Department of Anesthesia and Critical Care at the SCB Medical College. And she was also the Vice President of ISN National. With her, it will be co-chaired by Dr. Tanveer Samir, who is the Associate Professor of Anesthesia and Critical Care, PGI Chandigarh. She's also the lead transplant coordinator for the National Organ and Tissue Transplant Organization. With these few words, I welcome our speaker and our chairperson, and I hand over our mic to the chairperson so she can speak and introduce our speaker. Madam, please.
Before that, I'll request President Sir to say a few words.
Oh, sir. Oh, sir, actually, sorry,
No,
sir.
no,
Okay, that's fine. It's fine. Say just customary. Well, let's say a very good evening to all. I welcome you all in the webinar on this anesthesia and laparoscopy organized by Odisha branch of RSCP. I really congratulate Dr. Rekha Das and her team who are actively participating in the academic webinar series 2020 managed by the RSCP. The topic in this webinar are very useful and interesting. I am sure that with this sharing of the knowledge by speakers and with discussions, our knowledge will be updated and will be useful in the day-to-day practice. I welcome all. I welcome all speakers also. Basically, they are all stalwarts of the anesthesia specialty. Dr. Jayashree Sood, we all know her. She is a chairperson of anesthesia in Sir Gangaram Hospital, Delhi. Dr. Indrani, President-elect, and she is Professor and Head in Department of Anesthesia and KEIM Hospital. Dr. Sunil Pandya is Director of Prerna and Head of AIG Hospital, Hyderabad. Dr. Nitasha, she is AP in the Anesthesia Department, AIMS Bhubaneswar. We pay our gratitude to all speakers for sharing their experience for especially topic and sparing the time for the webinar. I am thankful to chairpersons who will conduct this webinar smoothly. I wanted to say you that the separation effort of the members and executive members and all members of RSP, they are cooperating and they are helping us to continue this CME programs. And Dr. Naveen Malhotra, our Dynamic Secretary, deserves a special appreciation, who is well pursuing every CME program to make regularity of the CME webinar, which is the aim of our RCP. I am thankful to all participants and for attending this webinar, who are showing the interest in this. With this, thank you very much. With regards.
Thank you,
I would now
sir.
request our Secretary National, Dr. Naveen Malhotra sir, to speak a few words and welcome the guests.
Thank you, Madam. Respected President, Dr. S.P. Sharma, sir, and other esteemed office bearers of RCCP, Dr. Indrani Himmat Kumar, President-elect, Dr. Sarvari Savaika, Vice President, Dr. Anju Grewal, Editor, led by our advisors, patron, Dr. H.K. Kaul. See, RSSCP is holding regular academic programs every fortnightly, and we're thankful to our city and state branches for conducting these programs regularly under the banner of RSSCP. And the show is going on, and I'm really very happy and congratulate the RSSCP Odisha branch led by Dr. Nivedita Pani and Dr. Rekha Das. And today's program is organizing chairperson is Dr. Rekha Das for organizing today's program. President and Dr. Rekha Das must have said good words for me, but the credit goes to the whole team. It is the team RSSCP which is working and ensuring that the academic programs under the banner of RSSCP are going on in this COVID pandemic also. Though we are not able to meet physically, but we are meeting regularly virtually. Most importantly, the whole credit goes to the speakers. They are the stalwarts of any webinar or any academic program. And today's stalwarts are really teacher of teachers. We have grown listening to Madam Jayashri Sood since we were born in anesthesia. When we are introduced in anesthesia, we have been listening to Madam, and we have learned a lot from her. And I'm very sure the delegates today will have a very good time listening to her and enrich their knowledge. I'm very thankful to Dr. Sunil T. Pandya for joining us today and speaking on the topic which he was supposed to speak 2 weeks ago, but due to some unfortunate, he was busy or circumstances, he could not attend. But I'm very thankful to you, sir. And sir is joined in the field of obstetric anesthesia. And I'm very sure the members will have very good time listening to him on the obese parturient. Then we have our own Dr. Indrani Hemant Kumar, who shall be talking about a very different topic, over-the-counter drugs. And I'm also keen to listen to that particular topic and what she has to offer to us. And I'm really excited about it. And I also welcome Dr. Nitisha Mishra, our young speaker from AIIMS Bhopal. And I also thank all the chairpersons also who have taken time out from their busy schedule to moderate these sessions and ensure that a good academic interaction occurs. I'll request all the chairpersons to please ask the question and answer immediately after the lecture. Otherwise, sometimes the speakers, they have to attend some other scientific program. So they can have the question and answer, invite the question and answer in the chat box and have the question and answer immediately after the individual lecture. Though we have got time for open house and question and answer in the end also. With this, I thank you all for joining us for today's webinar. And I'm very sure it will be a good academic venture. Thank you, all of you. Long live RSSP. Thank you very much. Over to you, Dr. Rekha Das.
Yes, sir. Thank you, sir. Now I would request our chairperson to kindly introduce our first speaker, Madam Jayashri Sood, Madam. Now over to Professor Nivedita, Madam. Madam, please, and welcome also Dr. Tanveer. Please.
Thank you, Professor Rekha Das, for giving me such a wonderful job. And I must give a nice welcome from land of Jagannath, Odisha, to everybody. A good evening to everybody. So I feel really honored to introduce Professor Jayashri Ma'am, who is really a, you can say, is a star in the anesthesia sky. She is the chairperson in the Institute of Anesthesia of the Pain and Perioperative Medicine, and she's the affiliation to Sar Gangaram Hospital, New Delhi. And her area of interest is anesthesia for transplant, thoracic, laparoscopic, and pain management. And she has got a lot of achievement. And she, to say that she has got the anesthesia, she has got the IMA Medica Healthcare Excellence Award in the 2019. And she is the Excellence in the Anesthetic Management as the Best Teacher Award in 2018 and Best Achievement Award 2011 from the Sar Gangaram Hospital. Not only that, she is a DNB examiner for MD and DA. She is the past president of the Indian Society of the Anesthesiology Delhi branch, ISSSP Delhi, and she has got a lot of oration to her credit. That Venkatra oration 2004 Isakan, Eskesa oration from the Ishakan 2006, Professor V. Rajgopal and V.G. Apakuchi Memorial oration, and she has got a lot of publication.
Nibeta madam, unmute yourself. Nivedita madam, please unmute yourself.
Maybe she has a problem with her internet connection, it appears.
I think.
Somebody has to unmute her. She may not be hearing you.
Someone has to unmute her or take over. Dr. Rekha Das, you should take over.
No. I think Naveen sir will do.
Tanveer, you take over because she has lost her
Tanveer,
connection.
please take over.
Yes, ma'am. So, ma'am, as madam has rightly said, Dr. Jayashree ma'am needs no more introduction. I think anybody who's attended her talks knows that she starts from the very basics and then she leads us to the higher level and the higher level. So I think I should not keep the audience waiting for more and we can give over to the speaker. So I invite ma'am to please share her experiences with us. Over to Jayashree ma'am.
Thank you very much for all those words of appreciation. I hope I live up to the expectations. Today, the topic that has been allotted to me is anesthetic challenges in robotic urological surgeries. Should I share my screen now?
Yes, ma'am. Yes. Ma'am, you can share.
You see, the host has disabled the screen sharing.
Go ahead, madam. Go ahead, madam. Madam, you have to unmute yourself. All others are muted. They can unmute themselves.
Is that fine? Can you hear me now? Hello?
Yes, madam.
Okay.
Yes, madam.
Right. Okay. Good evening, everybody. So the lecture that has been given to me is the anesthetic challenges for robotic assisted urological surgery. As the topic goes, we've been doing laparoscopy for so many years, but lately in the last decade or so, it is the robotic assisted surgeries that have come into the picture. And truly so, we must understand what this robo is. And it's very interesting. If you go into the history of how this word robo was formed, the history of robo goes back to sometime in 1921 when this was a gentleman by the name of Kepek, and he used the word robo in he was a playwright, and this was the play that he held, which was Rossum's Universal Robos, in which he used animated objects who were the slaves of the individuals. And that is how the word robo, from the thought that it is robo or slave. This came from the Czech word robota, which meant forced labor. So keeping this word in mind, it was really the NASA aeronauticals who first developed the robo in their aeronautical center. And this was used by the US Department of Defense later on. And what they did was that it was the surgeons who were in the aerospace, and they would use these robos to treat the victims in the Vietnam War. However, it was not very successful, but this was the birth of robo. So when you see in this diagram, in this photograph, it starts off with a laparoscopy. So laparoscopy had several limitations. We know that it gives only a two-dimensional view. There are restricted mobility of instruments and unfavorable ergonomics. What happens is that the surgeons, after very long surgery, feel exhausted. So these limitations were actually overcome in 1997 by the Da Vinci system, which is actually the master slave manipulator, meaning thereby it is the master remains the surgeon and the slave is the robo, and it is the master who manipulates the slave. Very often the patients come and ask the surgeon that robo hi karega na surgery, it will be the robo who will be doing the surgery. So they are under the impression that it's the robo who's doing the surgery, but nothing doing. It is the surgeon, and the robo is only a slave. Now let's see this. What is this system basically? So this Da Vinci surgical system has 4 components. You have the surgical console, surgeon's console. Then you have the patient cart, the optical 3-dimensional vision tower, and the endo wrist instruments that you can see beneath. So when you see the surgeon over there, that's the console where he's sitting. So the surgeon sits at the console. He has 2 high definition monitors. It's very important to remember there are 2 monitors that he's looking through. And what happens is at the end of the endoscope, the camera, the vision is coming through 2 different optical channels. And therefore, it seems that he has got 2 monitors, so he sees 2 visions like we see. And that is how you get dual independent optical channels. And that's how you can see the depth of 3-dimensional view, which is not seen in normal laparoscopy surgery. And it mimics a microscope or a binocular vision. And therefore, this is very convenient because in lab, you can't adjust or you can't estimate the depth of the organ, whereas here you can. So these are the, if you see here again, the hand of the surgeon, this is how he puts his index finger and the thumb, and these are the manipulator arms. And this is how the wrist movements that take place at this level. It's important to remember that there is a frequency filter which reduces the tremors. So if a surgeon has a tremors, anything more than 5 hertz gets filtered and the tremors are not there. So also there is motion scaling, meaning thereby that if the hand of the surgeon moves 5 centimeters, the robo at the other end, the arms only move by 1 centimeter. These things are very important for us to know because we are going to do a robotic anesthesia. So these things are very, very important. Now look at the console, look at the foot pedals that he has. He's got 3 pedals over there. One is for the cautery, one is for the camera adjustment. And this other one is very important that if he removes that, the robo gets disengaged from the robotic motion between the arms. So that's the safety. As soon as the surgeon, supposing he moves away, the robo stops. So he cannot continue operating. Now look at the patient cart. It has 4 arms. The first 2 arms that are there, they represent the right and the left arm of the surgeon who holds the instruments. The third arm, yes, he can position another endoscope in case he wants to do some retraction. 4th arm is optional. Now, what about the instruments? Look at these instruments, so important. Now, these instruments have a 7-degree movement. That means that the end of these instruments can have a full 7-degree. Like when we have the arm, the wrist, and our grasping, we do only limited movements. But this movement can be left, right, up, down, rotational, can all take place by the robotic arms, which the surgeon is manipulating. The optical tower has an accessory monitor, a camera head, and a recorder. So if you see, what are the advantages of a robotic assisted surgery? All the benefits of lap surgery, which you all are very well aware of, the small incisions, the quick reversal, and the short hospital stay, you know it all. Along with all the benefits of the robo, that is less tissue manipulation, fewer adhesions are formed, 3-dimensional visualization, enhanced degree of movement, scaling down of movements, ergonomic positioning. It's very important that the surgeon might do several hours of surgery, but because of the position at the console, there is reduced fatigue, which is a very important ergonomic factor. But there are limitations as well. We shouldn't feel that it has all the advantages. What is the thing? Lack of tactile feel. Naturally, he is so far away from the patient, so that tactile feel is not there. There is a learning curve. Yes, definitely, you have to have a few weeks. First of all, you should know laparoscopy, and then you should be able to go to the centers where the robotic teaching is done. Then you must have your assistant who is there by the patient side, as you can see there. He should also be a trained robotic surgeon. The instrument, the equipment is very, very bulky, as I'll just show you, and the setup times can be lengthy in the initial periods. Now, what are the robotic urological surgeries which are commonly done? And radical prostate has now become very, very common. That's one of the most commonest surgeries done by the robo. Then you have the nephrectomies, the radical cystectomies, adrenalectomy, ureterectomy implantation. So naturally, the indication increases. Now, I just got a few photographs for you to see. Those who don't know, the ones who know what a robo looks like and what is it, that's fine. But for those students who do not know, who have not seen, these are a very interesting slides. So you have this complete draping of the robo that is done. Then this is how gradually the robo is brought near the anesthetized patient. And then this is what is known as docking. Docking is one word you hear in my whole lecture. This is when you see the laparoscope, laparoscopes have been inserted. And then this is the docking over there. That green thing that you see is how you dock the robo. This is one arm in place. This is the whole robo in place before the surgery starts. So after having seen all this, now what are the surgeries? I'm not talking about the anesthesia concerns right now because there are a whole lot of them. So just discussing what are the surgeon's concerns. You must remember, and that's very important for us to know, this docking that I told you has to be done only after optimal positioning for surgery. Because once the position is obtained, optimal position, and docking is done, you cannot at all move the robo. That's very important. So your optimal position has to be done, and then the docking, and no movement allowed whatsoever, which is very important for us to know. Patients' trauma has been reported from the robotic arms. They're so heavy. Hemorrhage can be insidious. Communication is difficult. Now you saw that photograph where the surgeon is sitting in the console, and so you cannot hear what he's saying. However, there is a microphone there, as well as speakers outside. So when he's speaking, you can actually hear it like an echo that is coming. Now, so these were the surgical concerns. Now look at us. Look at what our concerns are from the anesthesia point of view. They are all the concerns of laparoscopy that we know, and the concerns of the robo. But just to recapitulate, what are the concerns of laparoscopy? We know it's the patient positioning, carboperitoneum, and the raised intra-abdominal pressure. And here to see, we know all the systems are affected. So just to name a few, the cardiovascular, the systemic vascular resistance increases, the mean arterial blood pressure increases, and the cardiac output may fall. And we know that all these things are inversely proportional to the raised intra-abdominal pressure. The higher the pressure, the cardiac output, the more the cardiac output falls. The pulmonary compliance reduces, and the peak airway pressures increase. All these you know very well in laparoscopy. Plus, urine output during laparoscopy procedures fall, the pressures rise, and catecholamine release might take place. What about the robo? The robo, there is spatial restriction. You saw that photograph. Once the robo is in place, you cannot by any chance get near to the patient. So your access to the patient is difficult, and absolutely to the airway, it's an absolute difficulty. You just cannot reach it. And extreme positioning of the patient can lead to even sliding off of the patient. So the positioning of the patient is very important. And again, I'm repeating, complete immobility. Now with this steep Trendelenburg position, several case reports have been there. Tracheal tube migration, you heard even in laparoscopy, but In these, because you have a steeper position, so the tracheal tube migration has been reported. And they have seen that after the drapes have been removed, after several hours of surgery, oral ulceration has been seen, the gastric fluid has come out of the mouth, and you've also seen risk of gastric regurgitation is there. Conjunctival burns because of this gastric fluid that has come out has been noted. Now, another important thing, as you can see in the figure, that is the intracranial pressure that is being monitored by the optic nerve sheath diameter. So the pressures can rise, the intraocular as well as the cranial. This point is very important because we've got elderly patients that are coming to us, especially the patients with the prostate surgery, malignancy. You have to assess these, and sometimes there can be problem. Plus, in case a patient has got some neurological problem. So these matters are of great concern. Plus, incidences of facial, orbital, and conjunctival edema has been noted. And it is said that if you see this kind of edema at the end of surgery, once the drapes are removed, they are all forerunners of laryngeal and pharyngeal edema. So if you see edema on the face, you must think of a laryngeal edema or a pharyngeal edema developing. This is a case report in which they have said there was a post-extubation respiratory distress. And this patient required re-intubation and ventilation. And what they noticed was that there was laryngeal edema. Probably the reason they said was because of the reduction in the venous outflow from the head due to the carboperitoneum and prolonged extreme Trendelenburg position. This was the cause of the edema. Pressure injuries, you have positional injuries. This you have seen if you have the lithotomy position, the femoral nerve can get compressed, or if you're any position that may be abnormal or for a very long time, if you're not taking care of the positioning and the padding of the patient, all kinds of, even brachial plexus, although in this case, the arms are by the side, but otherwise positional injuries are very, this thing to be remembered. Pressure and crush injuries are not common, but if you don't take care. Hypothermia, because you've got the insufflating gases going for a long time, this is of concern. And if you can see in the photograph again, that for these prostate surgeries, how we have covered the patients with the cotton wool, in addition to the warming that is done. Risk of deep vein thrombosis because of the, again, the position that is there and the Wilcox triad is affected, the risk of DVT is there, and this has to be taken into consideration. Another complication, the well limb compartment syndrome. There is rhabdomyolysis has been noted and a 3-limb compartment syndrome, again because of the extreme head-low position, the venous drainage from the limbs has taken place, and due to the raised intra-abdominal pressure, the venous drainage is affected. This is an interesting complication that I've written here, the mask phenomena. This is only one case report that I came across in which they said that after a few hours of extubation, small petechiae were only seen on the face and forehead and not on any part of the body, which disappeared after a few hours. And again, they thought that in this could be probably again because of the venous obstruction that takes place. So after having seen that it's not such a simple technique to follow, that yes, we are doing a robo-surgery, the anesthesia is very, very important. So you must take all precautions. Patient safety is of utmost importance. The patients are elderly, you must take high-risk consents if required, especially the elderly prostate surgery. These things have to be remembered. Now you see this emergency drill for redocking. Before going on to this, you must have a drill that just in case, in any case, inadvertently you have a catastrophe and you have to dedock, you must have an emergency drill that within a minute or so you have to de-dock the patient, and then the robo de-dock the robo, and then you have to start the resuscitation. So this emergency drill you all must know. Then, of course, in the aims is optimal positioning. As I said, that initially in the early years, when we like with our surgeons started, they would take a very steep head-low position for the prostate. However, now with over experience and with the new robos coming, somehow a lower Trendelenburg position, lesser degree of head-low is being taken. Optimal fluid management is very important because I said, because of all the edema that is there, that is developing, this is a very important factor. Analgesia, post-operative nausea, vomiting is all cognitive dysfunction. All these things have to be taken into account like any other surgery. And then, like any other surgery, we are having the ERAS protocol. So also for robotic prostate and maybe other urological surgeries, the ERAS protocols have come. So let's see, you have a pre-op examination, risk assessment.
Ma'am, just 1 second. Ma'am, just can you speak closer to the mic, please? Your microphone.
Okay. Can you hear me now? Can you hear
yeah,
me?
Yeah, better.
Okay.
Yes, better. Thank you. Sorry for interrupting.
No, not at all. So in the pre-op examination, the risk assessment and the DVT prophylaxis is very important. Mechanical, pharmacological. Now, depending upon your hospital protocol, you can give whichever low molecular weight heparin you want to give. But otherwise, the intermittent compression devices are absolutely fine. Rekha, can you hear me? Can you hear me?
Yes, ma'am. I can hear you, but someone saying that your voice is low, that is right. It's fine with me.
Okay. Induction, of course, it's an intravenous induction where the arms are kept by the side of the patient, because for the surgeon to operate, it's important that the arms should be by the side. So you need long intravenous extension lines. You intubate with the relaxant that you want to. The tube has to be fixed very well. And after the fixing has been done, the surgeon actually inserts the laparoscope. Slow CO2 insufflation, low intra-abdominal pressure should be always, that should be the aim. And then you position the patient. You position the patient, the surgeon positions till he gets the optimal view of the organ. And once he gets that optimal view, then the robo is docked and then no more movement is there. Therefore, continuous neuromuscular blockade has to be used. So again, this movement, no movement after docking, and docking after the patient position. Or what about maintenance of anesthesia? There has been a study in which they have compared the volume controlled and pressure controlled in a steep Trendelenburg for robo-assisted laparoscopic radical prostatectomy, and they found that a rate tidal volume of 6 to 8 ml per ideal body weight, and in their study they found that the pressure control was better than the volume controlled respiration or ventilation. For the maintenance of anesthesia, remember about the restraints and the pressure points. Now here again, because oncosurgery being a radical prostate may be done for the CA, so TIVA again has been found to be slightly better than probably the inhalation technique. Now that's a norm going for any oncosurgery whatsoever. And of course, muscle relaxation, adequate. It should be very good. You cannot have, in case the patient bucks, you'll have tearing of the robotic arms, which is not at all acceptable. So you have to have a continuous neuromuscular blocking agent. Restrictive fluid management is the norm. So now this was a study in which there are some people who have the elderly patient for long surgery. To prevent the increase in intraocular pressure, they have advised optimal positioning, controlled IV fluids, and also these three things: dexamethasone, furosemide, and mannitol. So they feel that this should be given, and it helps in the preventing the rise in the intraocular pressure and the intracranial pressure. Monitoring, ASA monitoring always. In the initial stages, yes, invasive monitoring is recommended. Airway pressure, Temperature monitoring, very important. Bispectral index, I'm saying for many people who are using a closed loop type of anesthesia. And then we have the optic nerve sheath diameter, which we have seen in long surgeries. It does definitely indicate some rise in pressures. At the end of surgery, once the surgery is finished, first you de-dock. De-dock the robo, then get the neutral position. And then before you do the extubation, that is, you must do a diascopy, you must do a leak test before extubation. So in case the leak test indicates that there may be laryngeal edema, naturally you cannot extubate. So this should be a part of your protocol. So this is the diagram which I've taken for the enhanced recovery after robo-assisted radical prostatectomy. So this is the general ERAS guidelines that we have and what we follow right from preoperative examination, right, and into intraoperatively short-acting muscle relaxants. So also the analgesia, even though we are doing such long cases, some reports are there of epidurals, etc., but we have not been using them. We have found that if you give multimodal analgesia with short-acting analgesics and as well as the non-steroidals, they are good enough, and you really don't require epidurals for post-op care. And then you have the PONV, the normal routine that you give, and then early mobilization. So these ERAS protocols are there even for the robo radical prostatectomy. So just the last few slides, what are the recommendations which are given for this evolution of this robotic surgery? Limit operation time, that naturally happens with experience. Minimize the Trendelenburg, that also has been started. Limit insufflator pressure, fluid restriction, and maintain the normal end tidal carbon dioxide. So understand the principles of robo, they are very interesting. The physiological changes in laparoscopy that you've been doing for so many years. Remember the complications, and a meticulous anesthesia technique is very important. Therefore, to conclude, the technology of robotic assistance has definitely overcome the limitations of conventional laparoscopy, and robotic assisted surgery has definitely got a role in the surgical practice. Thank you very much.
Thank you so much, ma'am. It was a wonderful talk, and we've got some very interesting questions which I would like to discuss with you. Now, the first question is that how do you manage the tracheal tube migration in the middle of the surgery? Now, I think this is...
One sec. Do I have to stop this slide share? 1 minute.
Yes,
do I have to stop the slide share?
Maybe, madam.
Yes, madam.
1 sec. I'll just see how to stop it. Can you stop? Yeah, so that was a good question, and you have to remember you just cannot do anything in the middle of the surgery at all. Nothing doing. You have to remember that it can do, but you cannot do anything at that time. You can only remember at the end of surgery, probably auscultate your patient well and to make sure that it has not migrated and it has not become one-sided. That's very important. So once you have fixed it well, yes, we say that you are doing, there is a migration of the tube, but what happens that is actually because of the laparoscopy, the intra-abdominal pressure rise, that both the things come up. The diaphragm also comes up and the tube also comes up. So that is one thing. And the other thing is good fixing and nothing will happen.
Ma'am, suppose the surgery has been for a very prolonged duration and slowly because of the tube getting migrated, it could be possible that slowly that site gets atelectasis. So then after atelectasis, when the patient is not able to maintain saturation, so have you ever, asked the surgeon to stop and de-dock? Has there been any such emergency?
No, nothing like that. You see, there are two things you have to remember. When we say that there is a proximal movement of the, see, when they say migration, then means your thing is not fixed well and it has moved up. But otherwise in laparoscopy, we say that what happens is your tube is very well fixed at the proximal end. So when the diaphragm goes up, so relatively you feel that it has come up, but it's not so. But when we're talking about migration, that is an accidental movement of the thing which should be You have to be very careful before you do anything like that. So these accidents, of course, are there if not done meticulously.
Sure, ma'am. Now we come to the next question. Now there's another question which says that have you faced any complications due to the long learning curve of the surgeons? Like, ma'am, that must be many years ago at your center.
Yeah, absolutely. We did have these elderly patients who post-operatively, that's why I said post-operative cognitive dysfunction. Yes, post-operatively, these elderly patients did have a post-op cognitive dysfunction, which probably because we were not doing the optic nerve that time, optic nerve sheath diameter. So that is possible that it was there. But now that we know that these things are there, so we give in our radical prostates, we give dexamethasone and mannitol.
So, ma'am, do you give it to all patients? Dexamethasone, is it a protocol?
Not all patients, the elderly patients of prostate who have some other comorbidity. Sometimes you get the healthy ones, so we do not, but in the elderly patients, yes, we do, who have some comorbidities as well.
Ma'am, do you feel difficulties in doing the optic nerve sheath diameter because, the robot arms are all around, the head is in steep position?
No, you can just fix them up first, well, beneath the thing, and then you don't have to remove it because you don't go near it. And it's important, which I probably missed out saying, that now it's a protocol that after 2 hours, actually, you de-dock, make the patient supine, and then go back to head flow, because that will also prevent these things, changes taking place.
Sure, ma'am.
After 2 hours, you make them supine for 20 minutes.
So do you do it, ma'am, at your center always?
Yes.
Okay. Ma'am, although you have discussed about the mode of ventilation, but there was still a query that people wanted to know that you have clarified that it's the pressure control which you use. So do you always use pressure control in your center?
Not necessary. These are studies, and as you've seen that they're, even if you take any surgery for that matter, whether it is this or whether it's robo-bariatric surgery, these controversies are always there. So it's not always so. Many of us, you are using volume control, but these studies have shown pressure might, just overtake the volume control, but not necessary.
And ma'am, then there's one more interesting question. They say, what is the longest duration that you have, given anesthesia for a robotic surgery?
In the initial stages, the surgeons, you mean only urological or in general? In general, it can be several hours. We've had vascular surgeries, we went in for 7-8 hours. And they especially, if you're doing a ureteric reimplantation and you've had some vascular problems. So we've had all those sorts of things. But in case there is any problem with the bleeding, the surgeons have a very low threshold of stopping the robo, de-docking, and then opening them up. So that safety is very, very important. But if it's going smoothly, yes.
So the surgeons have a low threshold.
Oh yeah, absolutely. Nothing. We just don't keep on trying and trying.
Yes, ma'am. And ma'am, one more.
That initially you have several hours of anesthesia, but then over, once their learning curve is also over, now they finish it within 4 hours.
And ma'am, one more question. As we are anesthetizing elderly patients, we have lots of patients with cardiac issues. So we have patients with low EF. Now we can't give a lot of fluid also. So is there a threshold at your center where you advise somebody that you look, your EF is very low, or you're a very high risk cardiac patient, you should not undergo robotic? Is there anything like that? Do you?
No, actually, if you see different protocols in different hospitals, well, ours being a tertiary care, and we've been doing laparoscopy for a very long time, and now of course robo, but we are using goal directed fluid therapy. You see, it's always, we are using our monitors, hemodynamic monitoring, which can determine the fluid rate. That is there. We see the stroke volume variation. But if the surgeon wants to do a robo, and again in a patient who has gotten a low ejection fraction, we do explain the risk to the patient. Of course, we do explain to the risk, but we haven't really, we can say we have refused or rejected any patient. We explain to them and then take the precautions.
Ma'am, so
this is because we've been doing it for several years, but in the initial years, it's always better to play safe. Don't take the very high risk patients.
So I think, ma'am, we can take the rest of the questions at the end.
Yeah, sure. Thank you so much. Thanks a lot.
Over to Dr. Rekha now.
Naveen sir will yeah. Thank you, sir. So this has been an excellent presentation by Madam. And I think there are still few more queries by many people. And I too have a query. I think we shall have it clarified at the end, if it is possible, if time permits. Then we go over to thank you, Madam, again. And with these few words, I now go over to our next speaker, who is none other than our President-elect, Dr. Professor Indrani Hemant Kumar, Madam. And she will be speaking over-the-counter drugs used for weight loss. How safe are they? And this session will be chaired by Professor Sarbari Swaika, Madam, who is the Vice President of RSCCP. And she's also the HOD of the Emergency Medicine and Trauma Care at IPGMER, Kolkata. And the co-chair is Professor Major Pramod Patra, who is an experienced anesthesiologist in the field of cancer surgery. And he is presently a senior consultant at SCG Panda Cancer Hospital, Cuttack. With these few words, I hand over our microphone, our device to Professor Sarbari, Madam. Madam, please invite and introduce our speaker. Ma'am, you are not audible. Dr. Sarbari, you are not audible. Yes.
Yes. Very good evening, one and all. Thank you, Dr. Rekha Das, Madam, for inviting me to this nice RSSCP scientific academic webinar. And at the outset, I convey my heartfelt gratitude to the respected patrons of RSSCP, Dr. Tej Kaul sir and Dr. Avtar Singh sir, Dr. S.P. Sharma, the president, and Dr. Naveen Malhotra, honorary secretary of RSSCP, and all the esteemed delegates. All of you know that the prevalence of obesity is rapidly increasing throughout the world, and correspondingly anesthetic procedures in obese patients also rapidly increasing due to both treatment of obesity as well as some other surgical problems encountered by the patients. And we know that pharmacological treatment is one of the most important part of obesity and is widely available. Many patients take anti-obesity medications or herbal or homeopathic remedies over the counter and consume them not as medicine. So now I take the opportunity to introduce none other than Dr. Indrani Hemant Kumar, Madam. She is the professor and HOD of anesthesiology at St. GS Medical College and KEM Hospital, Mumbai. She is a great academician, as we all know, and she is a renowned teacher having more than 31 years of experience. She ranked first in DA and MD anesthesiology in Mumbai University. She obtained Hargobind Fellowship to train in cardiac anesthesiology at Lehigh Valley Hospital, Pennsylvania. She has authored 28 publications across various journals to her credit. Her area of interest is in obstetric, pediatric, cardiac anesthesia, and critical care. She is the president-elect of RSCCP National, and she is a past president of ISM Mumbai. She was the organizing chairperson of ISACON 2011. She has been awarded with Bharat Jyoti and Natya Kalaimani Award. She will be presenting on over-the-counter drugs for weight loss. Are they safe? So over to Dr. Indrani Hemant Kumar, Madam, please.
Thank you so much for this elaborate introduction, Dr. Sarbari. Respected chairpersons, my seniors, and stalwarts of RSACP, I would like to thank RSACP Orissa branch for this opportunity to share this offbeat topic. And it is of a lot of great interest especially to middle-aged, obese people like us who are constantly fighting the flab. So the topic is over-the-counter drugs, herbals for weight loss, and are they safe? So let's see. So if you see, millions of people are on a diet, right? And it is $1 billion industry. And at the end of it, how much has been the weight loss after spending millions, after spending thousands, if you say in India? Weight loss is hardly less than 5 pounds or 10 pounds. And even if you have lost more kilos, 95% of the weight loss is regained within 5 years. So all this in pursuit of a lovely figure. Now, what is the history of weight loss? So this Soranus of Ephesus, way back in 2nd century AD, what he did was he started the first weight loss treatment. And what he did was he gave elixirs of laxatives and purgatives, as well as heat massages and exercises. And this phenomena of giving all these elixir was there, it stayed for almost 1,000 years. Moving on to the 20s and the 30s, thyroid hormone patients were losing weight. So that became very popular. So even patients who did not need thyroid hormone, those who were heavyweights, they consumed thyroid hormone hoping to lose weight. But what happened with that was patients with, they had palpitations and, difficulty in sleeping. So all these side effects were there with the thyroid hormones. Then later on in the 30s, dinitrophenol was introduced because it causes uncoupling of the biological process of oxidative phosphorylation in mitochondria, causing them to produce a lot of heat. So the metabolism went up. So the most significant side effect of this was warmth, frequently with sweating, and patients started getting fatal hypothermia. Then the 30s, in the end of 30s, we started getting people taking amphetamines. So this was basically to suppress your appetite. So, and to increase your alertness. But then, and other products which were very commonly used were laxatives and diuretics. And of course, they found that apples, cheese, and red wine assisted in losing weight. So, but then, but you know that by using lots of laxatives, you can have hypokalemia and then arrhythmias following that. So then in the 30s, again, we had a rainbow pill. A rainbow pill, it's a combination of just about everything what I said just now. It had amphetamines, thyroid hormones, diuretics, digitalis, laxatives, barbiturates, and you can imagine it had all the side effects of these stimulants. Coming to the 60s, that is when we started having patients, report of patients dying because of these diet pill death. So when that happened, the Senate investigated these diet pill and then they started banning amphetamines. In the 90s, fenfluramine was very common for weight loss, and they found that it caused valvular heart disease, and then death because of that went up to almost 30%. And in 2004, and ephedra was also being used very commonly. And in 2004, ephedra was withdrawn because of strokes and death. So the basic facts about over-the-counter remedies, majority of them are herbals, and they are generally anorexians, fat absorption blockers, or thermogenics. And then the long-term effects of most of these medications have not been established. So this is what happens. So isn't there a magic pill? So what are the magic pill we are looking at? One is appetite suppressants. In this, I would be discussing Hoodia and the pink patch. Then the fat absorption blockers like Chitosan and Ali, and thermogenics like ephedra and bitter orange, and exercising enhancing supplements like creatinine and L-arginine. So the appetite suppressants, what it does, it tricks the brain and it blocks the circuitry in the brain that gives the body those cravings. So we are looking at Hoodia. So the Hoodia, it comes as Hoodia spray, Hoodia shake, then Hoodia syrup, Hoodia coffee, Hoodia tea, fruit bar and etc. and all that. Well, it is an appetite and a thirst suppressant. It is not just an appetite suppressant, it is also a thirst suppressant. And actually, this was taken up by those hunters earlier when they went on long, hunting trips where they didn't want to have lots of food or, they couldn't get water. So this was used as a appetite and thirst suppressant. And that time they found they lost a lot of weight during those hunting trips. So that was given, but then this effect was converted and they started selling Hoodia spray, and it was just a hype, hoopla, whatever you want to call it. And there was no evidence of either safety or efficacy, and there were major questions about the actual product content. And Hoodia, when they marketed it as a weight loss wonder, they found that the patients who took Hoodia, they had liver function deranged. So they had drug interactions. It increased the blood pressure. It causes hypoglycemia, and then it causes depression. The safety in pregnancy in children was not established. Patients also had dizziness, nausea, vomiting, call it because of hypoglycemia or whatever. And more than anything, the death was mainly due to dehydration because the patients would not feel the thirst. So that was the problem with this Hoodia. So next came the pink patch. Now look at the way it is being marketed. 5 pounds in 2 weeks, no fuss, no effort. All that you have to do is put a patch, this pink patch, and that contained fucus vesiculosus. So the pink patch, it does all the weight loss for you. It eliminates hunger pangs, it burns more fat, it gives you that extra get up and go. That's the kind of advertisements you get. So it curbs appetite, increase the metabolism and energy, right? The fucus vesiculosus, which is there in the patch, it reduces excess weight by increasing the metabolism. The airway also increased, it causes appetite suppression. And the lecithin is aiding the body's breakdown of fat and cholesterol and helps in distributing the weight. And the 5-HTP in the pink patch, it is a natural mood enhancer and also helps you curbs the appetite. So the pink patch gave no information on the dosage of their ingredients. So we don't know if they are, by using it, whether we are using potentially dangerous levels of these drugs. And there are exaggerated claim of weight loss. So the US federal FDA commission, they filed a lawsuit against this manufacturers of pink patch. And that's how the pink patch was withdrawn later. Then we came to fat blockers. So what are the fat blockers? Orlistat or Ali, which is how it is called, Ali. So it is again a non-prescription drug. So what it does is it blocks the action of lipase, an enzyme in the intestine that breaks down fat. So makes serotonin works effectively, and it acts also as a stimulant. So 5 to 10% of the weight loss occurs in a year. And they claim that it also assists in long-term maintenance of weight loss. But what is the problem with Orly? Because it is a fat blocker, it causes steatorrhea. So frequent oily bowel movements are there in these patients, which is hard to control. So they have gas, which is embarrassing. They have liver failure, increase in blood sugar. Gastrointestinal problems may interfere with the absorption of obviously fat-soluble vitamins. So they have deficiency of fat-soluble vitamins and other important nutrients. And obviously, if you have fat-soluble vitamins, liver is going to fail at one point of time. And more than anything, Ali caused immune suppression, anaphylaxis, and exanthema multiforme. This is, if you look at if you go to the website, you will find this same lady who used Ali and developed the same skin manifestations because of Ali. Then we come to the most common, ginseng, which is being marketed even today as a weight loss drug. Well, ginseng, as compared to so many drugs, it is definitely effective, but the weight loss effect is by its effect on gut microbiome metabolism and fat absorption. So the effect varies with different individual based on the pre-drug gut microbia. So if you already have a normal microbia, then the weight loss is not so much. It tries to alter the microbial the environment in the intestine and block the fat absorption. So generally it is safe, but it can cause headache, menorrhagia, insomnia, hypoglycemia if you have taken it in very, very large quantities, large doses, and it interacts with antidepressants, ondansetron, furosemide. It reduces its effect. Then we come to thermogenics. So what does thermogenics do? It increases the metabolic rate, reduces the appetite, and increases the insulin level, delivering more energy to muscles, hence avoiding it from being stored as fat. So amphetamines were very commonly used. It elevated the mood and produces some modest weight loss over a short term, but presents serious risks of addiction, agitation, arrhythmias, insomnia, abdominal pain, diarrhea, dizziness, mood swings, nausea, nervousness, confusion of thinking and expression, vomiting, weakness, you name it, and you had an array of adverse effects because of amphetamine. See, look at this. This is no medication. This is the activity in the brain with absolutely no medication. And look at the activity after the amphetamine. So it causes hyperactivation of the central nervous system. So its side effects are extremely dangerous. It was withdrawn in 2002. It causes heart disease because it can cause coronary artery. It can cause coronary spasm, hardening of the arteries, high blood pressure, high pressure in the eye. It can cause glaucoma and overactive thyroid gland. All of them can lead to dangerous side effects, including death. So we come to sympathomimetics. The most common sympathomimetic which was used and marketed was fen-phen or Xanadrin. Again, a very, very popular over-the-counter drug. So the main ingredient was ephedra, which is again an amphetamine-like compound. Ephedrine is actually a precursor of adrenaline. All of us know that. It relies on indirect stimulation of the adrenergic receptors by increasing the activity of noradrenaline at the postsynaptic alpha and beta receptors. So it causes acute thermogenic and lipolytic effects based on the basal metabolism and appetite suppression for almost 9 hours. That is the reason it was very, very popular. As you know, adverse effects, it can cause coronary spasm, primary pulmonary hypertension, valvular heart disease, hypertension, tachycardia, central nervous system. I showed you it can cause overstimulation, restlessness, dizziness, insomnia, tremor, headache, psychotic state, agitation, flushing, sweating, more than anything, blurring of vision. And of course, it has other adverse effects on GIT, endocrine, etc. Now coming to one of the cases who used to take this drug. He was a 26-year-old budding actor, the son of a very famous producer, the foster son of a very beautiful woman, very beautiful actress who died 2-3 years back. No comorbids, bariatric surgery was planned. As soon as he was taken on table, the anesthetist found on the multipara monitor, the boy was getting multiple VPCs on the scope. So they didn't want to take any risk because another very, very famous actor was waiting outside the OT. So then cardiologist's opinion was sought and the case was postponed on reviewing his medication, he was on Mahuang for weight loss. So that was the one which was causing all kinds of arrhythmias, and they had to defer the surgery on this patient. Again, Mahuang is being taken by athletes for increasing their vigor and energy and everything. So again, this very famous athlete, pitcher Steve, he died during one of the training camps, and the family filed a lawsuit against Zenedrine, which is Mahuang. So that is also being recorded. We have pseudoephedrine. There are some people who think, because it's available in syrups, and then it helps you, the hunger pangs are abolished with pseudoephedrine. So, and it gives you a high. So people have taken pseudoephedrine for weight loss. But then please remember, it can cause hemorrhagic stroke, closed angle glaucoma in many of the dieters. Sibutrin, again, Meridia, very, very famous in the late 90s and 2000s, but it was recalled in 2010. And it inhibits the reuptake of serotonin, norepinephrine, and dopamine. So it increases, again, it causes increased metabolism, feeling of fullness, appetite suppression by tricking the brain. So it did everything. And in fact, many studies were done, use of Sibutrin versus placebo. And they did find that there was patient against placebo, the heart rate was much higher in patients on the Sibutrin group. The blood pressures were much, much higher in the Sibutrin group as compared to the placebo. So it was withdrawn in 2010. Next is Herbalife. Herbalife, who doesn't know Herbalife? Shakes and tablets, the famous advertisement, lose weight now, ask me how. So that was the famous thing. It's a protein shake, and what they do is you have to replace 2 meals with these protein shakes and take this cell activator tablets. And it is meant to target specific weight loss needs. And then it's meant to support your by increasing your metabolism, reducing fluid retention, burning fat, and building energy. Till 2004, it also had ephedra. But later on, because ephedra was withdrawn and FDA took objection, they abolished, they removed the ephedra from the ingredient. But then the other ingredients which was there in Herbalife was known to cause lymphocytic leukemia. It produced estrogen, so cancers were susceptible in ladies, tachycardia, hypertension, nervousness, headache, allergic reaction, liver and kidney failure, cardiomyopathy. In fact, the one who was the founder of Herbalife, he was barely 44 years old, and he was giving advertisements saying that I claim my fitness to Herbalife, and he had a sudden death at the age of 44. So he was the founder of Herbalife. So cardiomyopathy is possible, skeletal muscle weakness. My own friends who had developed skeletal muscle weakness and had to sit at home. Interaction with prescription drugs are also seen with Herbalife. So lastly, the fat and the carb blockers. So the advertisement basically is flush the fat with Chitosan pills. So do you find it difficult to cut down on delicious food filled with carbohydrates such as pasta, cakes, breads, potato chips, and ice cream? And if you said yes, then you're not alone. But now with this drug, we offer you 100% safe and stimulant-free natural product that will allow you to indulge on occasion without having to feel guilty about eating carbohydrate-loaded or sugar-rich food. Isn't it fantastic? So what is Chitosan pills? It is a dietary fiber from shellfish. So what it does is, it is positively charged, and it attracts the negatively charged oil, fat, carbohydrates, phosphate, and heavy metals, and it absorbs 6 to 10 times its weight of fat and oils and forms a gel. And it's known to lower the cholesterol and promote weight loss. But what are the adverse effects of Chitosan? Weakness, gas, bloating, diarrhea, deficiency of fat-soluble vitamins because it's a fat blocker, hypoglycemia, uncontrolled bleeding during surgery because of antiplatelet effect, anaphylactic reaction with shortness of breath, facial swelling, palpitation, wheezing, or even shock. Well, all of us we take green tea and hoping that it can cause weight loss. Well, it contains propolyphenols and it's a strong antioxidant. It may help lower cholesterol and triglycerides and enhance weight loss. But some of the green teas can have caffeine, remember, and it can lead to restlessness, tachycardia, and insomnia. So be careful about even green tea. Read what is there in the green tea. And people taking aspirin or blood thinning medications should consult a doctor before taking green tea extracts because they also can have anti-platelet effect and it can enhance bleeding. And dietary herbal teas, not green teas. Remember, these are dietary herbal teas, diet teas. So what do they contain? They contain laxatives, which cause constipation, dehydration, and sometimes even death. So be careful when you're looking at your green tea. Read and then have it. So are they safe? They have untoward cardiovascular effects. They enhance potential for bleeding, potential for prolongation of anesthesia, interference with anesthetic agents, possible renal involvement or hepatotoxicity. We have had patients on these herbals and on post-operative day 2, day 3, the SGOT, SGPT rising high. So they have involvement, they can have hepatotoxicity post-operatively, potential for glucose disturbances, abnormal thyroid functions. Remember friends, herbals, surgery, and anesthesia don't always mix. They cannot be used together. And I would like to enumerate few real life OR cases. In 1998, we had, it's been published, a 30-year-old patient for an emergency surgery. They found that the blood pressure was 250 by 140, required multiple antihypertensives, including nitroglycerin IV. And post-operatively, when the patient was asked, he admitted to using ephedra. Then another case where a 30-year-old patient for emergency surgery, this was, I think this I've already said, and then patient for an oral surgery, massive unexpected bleeding was there during oral surgery, post-operatively admitted to herbal drug used for weight loss. So this patient bled more than normal, where you are expecting a 400 ml blood loss, this patient had about 3 liters blood loss. So that was the problem in these patients and he admitted to using weight loss herbs. Then a patient undergoing elective back surgery, intra and post-op, there was unexpected bleeding, there was oozing, and on inquiry, this patient was taking multiple herbs until 12 days prior to surgery for various reasons, or whatever, not necessarily for weight loss, it was for other things, for diabetes, for his skin, and other ailments he was taking. So this patient also was bleeding. So there is absolutely no quality control for any of these drugs. They are considered as dietary supplements or nutritional supplements, and there is no requirement for proof of efficacy, proof of safety, standards for quality control, cannot promise a specific cure, but they may claim a lot of effect. Burden of proving product unsafe lies with FDA. So FDA has to prove that this is unsafe to withdraw the drug. Variability between manufacturers and batches, potency affected by growing conditions, storage, handling, preparation. So there is a 10,000-fold difference in potency with each and every batch. So much of difference with every batch. So, and also they can have contaminations. So mandrake, that is scopolamine or reserpine in some preparations, belladonna in the herbal tea, digitalis intoxication was there. Heavy metals were contaminated in some of the products. So American Society, the ASA, they have acknowledged that adverse reaction potential of herbal medicines for them. And what they recommended was, if you are giving anesthesia, ensure that they stop taking all herbal medications at least 2 weeks before surgery. So that is the ASA recommendation. So friends, all these diet supplements, they have dangerous side effects. You quit taking them and the weight almost always comes back. If any of the diet pill worked in a long time, they would be sold by a giant pharmaceutical company, not a small level, multi-level marketing company. Remember that. If that is a long-term solution, the giant companies will take over, and midnight infomercials and obscure websites cannot, they will not be able to do the advertisement. So most weight loss products are marketed as nutrition supplements or herbal products, but actually contain hidden, unsafe, dangerous concoctions of hidden ingredients like seizure medications, blood pressure medications, antidepressants, or compounds that have been inadequately studied. So they give a promise of a miracle weight loss. And unfortunately, they don't live up to their claims, and there is so much of uncertainty about the dangerous side effects. So look for potential warning sign of tainted products, promises which are too good to be true, promises of a quick fix, lose 10 pounds in 1 week, use of words like guaranteed or scientific breakthrough, products marketed in foreign languages, in mass emails, products marketed as herbal alternatives to an FDA-approved drug or as having effects similar to prescription drugs. So many dieters stay in pursuit of the magic pill, hoping that the next one which hits the market, it will help them succeed, reach their weight loss goal without any side effects. But weight loss needs time and a lot of commitment. There is no easy fix, no magic pill to lose weight. And it's always what works is the good old fashioned eat right and exercise regularly. Thank you very much.
Thank you, madam. Excellent presentation. I have no words to say a few words. It was really, really excellent presentation. Let me see whether there is any questions in the chat box. Everybody praised the Lord. And
thank you so much.
There is no question for madam. Thank you, madam. Once again.
Thank you so much.
Thank you, Indrani ma'am, for your extensive and really eye-opening description of the defatting pills. But as we all humans know that our need and greed is the main cause for all these things to come up. And the main reason, other than medical reasons, social reasoning is the main reason for which these defatting drugs and pills are coming over the counter for use by the public. And you have really opened up.
And the market is using the desperation,
Exactly. And you have very nicely explained everything in details. So, and you have gone into the depth of history, which is a very good thing for us younger people and students, and even for the public. Thank you so much for that. And as seeing the chat box, there's no questions. In fact, all are stumpbound by your explanation that they don't need to ask any questions. Thank you so much for the extensive description. Now I go over to Rekha ma'am for the next session. Thank you, everyone.
Thank you.
Yeah, ma'am, sure. There is one question in the chat box. That is precautions during emergency surgery. What are the precautions we have to take during emergency surgery?
It's just come now. Yeah.
See, if it is, these are all herbal pills, right? So we don't know the. So what are the drugs? So you have to do it only a symptomatic treatment. You have to give only a symptomatic treatment. If the patient is having arrhythmias, you have to treat the arrhythmia during emergency surgery. If the patient is bleeding, you have to give blood and blood products. So there is no way you can, if the patient is having hypokalemia, you have to treat that. That is why, these are herbal drugs. So we don't have, those which can counter these herbal drugs generally. So you have, it has to be during an emergency, it is always treating whatever complication you're facing in front of you. But if it is an elective surgery, you have to postpone, you have to wait for at least 2 weeks.
So, madam, history taking is also very important.
Exactly. So we generally, we skip these herbal medications. Is one thing, we generally skip because, that is one thing, but that should be kept in mind.
And what type of...
Thank you. We are running out of time. Can we switch over to our next speaker? That was indeed a very nice talk by Dr. Indrani. It's a very relevant topic and a lot of research. I must really congratulate you for a lot of research you have made into the history. It has been a story. It's like a story for all of us. And I'm happy that it is in the YouTube. We can reread it. And thank you again. I thank our chairperson, Dr. Sarbari Savekka and Dr. Pramod Patra. Now we are over to the next topic by Professor Sunil Pandya on obese parturient, and our chairperson is of Anesthesia at MKCG Medical College. He's a dynamic anesthetist and a strong support pillar for any academic activities that are taking place in Odisha. And the co-chair is Dr. Sukanya, who is the professor and head of the Department of Intensive Care and Anesthesia at the Government Medical College at Chandigarh. And now over the webinar to them. And Dr. Basant Pradhan, please introduce our speaker. Dr. Basant Pradhan.
Thank you, Professor Rekha Das. Once again, I welcome you all to this webinar on laparoscopy and anesthesia organized by RSACP Odisha chapter. I am privileged to be here and I am thankful to Professor Rekha Das to organize this webinar during this COVID pandemic. And I welcome the speaker of the topic, that is Dr. Sunil Pandya, T. Pandya, that is, he is the Chief Department of Anesthesia, Perioperative Medicine and Critical Care, AIG Hospital, Hyderabad. Dr. Pandya has completed his MBBS and MD Anesthesiology from Osmania Medical College, Hyderabad. Then he did his fellowship in neuro and cardiac anesthesia from Sri Chitra, Trivandrum. He has acquired a vast experience of 2.5 decades as founder director, Prerna Anesthesia and Critical Care Services, Hyderabad, head of the obstetric anesthesia at Fernandez Hospital, and as director, Department of Anesthesia at Century Super Specialty Hospital, Hyderabad, prior to this present designation. A lot of certificates are credited to his experience as guide, faculty, and also as instructor in ATLS, CTLS, and WFS, and fellow of Critical Society, and he is an editorial board member to the Journal of Anesthesia and Clinical Pharmacology, as well as Journal of Obstetric Anesthesia and Critical Care, and he is a peer reviewer of Indian Journal of Anesthesia, Indian Journal of Critical Care, Internal Journal of Clinical Anesthesia, with 14 publications to his credit. He has participated as faculty in more than 50 national, state, as well as international conference. Now I welcome Dr. Sunil Pandya. The topic is a very interesting topic, that is obese as well as parturients. Obese parturients, the lot of challenge to the anesthesis always. And at present he is the president of Association of Obstetric Anesthesia. I welcome you, sir, Dr. Sunil Pandya. Please start your topic.
Good evening, all. My screen is visible?
Yes, not yet.
Yes, you are visible.
My audio also is okay, no?
Yeah. Yes, perfect.
Thank you, RSSCP National Executives, for giving me this opportunity. Thank you, Dr. Pradhan, for your elaborate, kind words and introduction. Dr. Rekha Das and Dr. Indrani for giving this opportunity to be here in front of you for the next 25 minutes. So next 25 minutes, I should be talking on this topic of obese parturient and moving away from over the counter. Let us handle exact obesity, what it means. And I shall be narrating my experience and what we have encountered last 25 years at Fernandez Hospital and other hospitals where we practice high-risk obstetrics, and the challenges that we have encountered, along with evidence and the current guidelines. So basically, greetings from Prerna team, greetings from AOA India, and greetings from Fernandez Hospital. Tertiary care center, we do almost about 8,500 plus deliveries, 65% acceptance for labor analgesia, and we have on-demand OB critical care as well as 24/7 painless delivery services. And this is the hospital where we practice mostly level 4 obstetric critical care. Well, main conflict of interest, and the pictures that are there in these presentations are obtained with patient's consent. So anybody using this presentation, please read those pictures. Look at the global problem. Yes, over the years, if you see by 2030s, the obesity is going to increase. It is progressively increasing. And currently around 2020s, if you see, almost about 45% of population is generally obese, especially in the developed nation. And this is the data from our country. It's an old slide, but still there is a tenfold increase in BMIs as over the years. And if you see the frequency with which the obesity is increasing, the morbid obesity population in pregnancy is increasing even in our country. As far as pregnancy is concerned, 1/3 of women, at least in our hospital, are more than 35 BMI. And at least about 12% are BMI more than 40, and 7% of BMI more than 50, and at least 3% BMI is more than 70. So there's a magnitude of problem that we have at Hyderabad at our hospital. And as I said, 50%, if you put the BMI as 30, almost 50% of pregnant women come under obese category. But generally, our cutoff at our hospital, we have defined as 35. 8% of reproductive age group women are extremely obese, putting them at greater risk of perioperative or peripartum complications. Importantly, the comorbidities that are associated with pregnancy, like diabetes, hypertension, coronary artery disease, especially hypertensive disorders, are with increased prevalence. This was our own study that we conducted in 2007 and 2008. And if you see the incidence of comorbid conditions like hypertensive disorders, as the obesity increases, the incidence of hypertensive disorders also increases. Like in morbid obesity is almost 10.7%, in obese 3%. So as the obesity increases, the incidence of chronic hypertensive disorders increases. We know that chronic hypertension per se is a risk factor in the peripartum period because the incidence of perioperative pulmonary edema is very high compared to just simple preeclampsia or severe preeclampsia. And if the obesity increases further, superimposed preeclampsia on chronic hypertension also is very, very common. These are our own hospital data with significant p-values. And if you look at the incidence of encountering us for anesthetic needs, the incidence C-section rate is almost about 70%, 65 to 70% in morbid as the weight increases. So anesthetic challenges, perioperative challenges are ever increasing, and these are the chunk where we need to have a very meticulous problem. If I look at the data of our own ICU, the commonest cause of ICU admission at Fernandez Hospital is almost about 48% of hypertensive disorders. And surprisingly, or not surprisingly, 32% of these patients have underlying obesity as the cause of admission. So basically, you have obese parturient, you have obese parturient with bundled of comorbidities, and importantly, it is a time bomb because there are several risk factors not only to the mother but also to the fetuses and the newborn. And importantly, it's a multidisciplinary team approach. And all the complications that can happen in severe preeclampsia, they happen with increased and higher incidence and with more sort of severity in this subset of patients with underlying obesity. If you look at any mortality reviews, why mothers die, saving mothers' life, Michigan maternal mortality review, hypertension, obesity, and the maternal death risk is very high if the patient's BMI is more than 35 to 40. And almost 80% of mothers in Michigan audit had obesity as an underlying prevalence factor, and the mothers who died. And why this is important? Because even if you look at the peripartum organ support, the ventilatory support needs, almost 12% of women with obesity, with hypertension, they require ventilatory support. And incidence of major obstetric hemorrhage also is very high. So also multi-organ dysfunction syndrome and maternal death. So obesity has alarming consequences, especially in pregnancy, and many risk factors for maternal death. And this is what we need to be prepared for. So whenever we have to anesthesia, provide anesthesia, safe anesthesia for this patient, you have to have a very meticulous planning, plan A, plan B, plan C in place. because we talk of a partiality with a back like this, where there are no landmarks, there are only bumps and lumps and folds, and you need to create a space to put a epidural catheter. Or a airway without neck or a receding chin may compound the problems further. So I'll just start off with a case which we had a few years ago. 23-year-old, primary gravidas, 27 weeks pregnant, referred for anesthesia consult rightly. BMI of 54. As usual, coming with chronic hypertension, diabetes. Now, if you look at the literature says that most of the women, despite so much of bundled of problem, because pregnancy is considered something social, they are unaware of the problems that can happen during delivery, immediate delivery, after delivery, or in the post-operative period. So it is very important on the part of the obstetric medicine team in your hospital, or the anesthesia department has to liaise closely with the obstetric medical team, so that patients are seen at least 2 or 3 times in the antenatal period. Generally, we see the patient around 20 to 30 weeks. There is a second peak of cardiac output, so that we can, if at all the woman becomes breathless, we can do an echo and other things and stabilize the woman. So it is very important that we see the patient at least 2 or 3 times before the patient actually comes for anesthesia or analgesia. In our hospital, all patients with BMI of 40 and above, irrespective whether they land up for cesarean section or labor answer, they come for institutional delivery, and PAC is mandatory. So to an extent, risk mitigation process is started early in the antenatal period. So whenever the patient comes to PAC, look for comorbid conditions like especially GDMs, ischemic heart diseases, very common actually. And even if you look at, we have our own data from histopathology of placental examination of all these obese parturients, the incidence of atherosclerosis starts during pregnancy. So these patients, even despite a normal course during pregnancy, they have a very high incidence of subsequent development of diabetes, hypertension, early onset of coronary artery disease. So you need to look for IHD as well. And of course, obstetric sleep apnea is a part and parcel of obese parturient, especially even though they have no OSA, but they become OSA-like thing with superimposed preeclampsia or even with simple mild hypertension. And of course, you need to look at the other needs, infrastructural needs of the OT and the ICUs. The ICU bed has to have a capacity to bear at least about 350 kilos, or the OT table should be a bariatric table. So pre-anesthetic check cannot be undermined. Detailed history taking cannot be undermined. And what all Dr. Indrani mentioned, over-the-counter drugs are common even in pregnancy, antenatal period. Some of them they take. So all these histories is relevant. Of course, it is with less frequency, but we need to have a detailed history, because we have seen at least a high socio-economic strata woman, obese, diabetic, smoker, alcoholic, and pregnancy. This combination also we have seen, and I don't say it is very rare. We see it really at least about 7-8 times a year, this combination. So assessment of airway, assessment of back, comorbidities, not to undermine the deepening reflexes, the GCS, JVPs, and labs, especially when the patient has under superimposed preeclampsia or a seizure. Because many times the patient have subtle signs of obesity, severe preeclampsia, HELP syndrome, anisocoria, which may indicate intracranial space occupying lesion or endopneumonia bleeds. So not to undermine that GCS assessment and JVP assessment and assessment of thing is clearly documented, so that intraoperative monitoring of pupillary size also should be a part of routine monitoring, because many times as an anesthesiologist, we do non-invasive or sometimes invasive, but intraoperative pupillary size monitoring also is mandatory, especially if the patient has uncontrolled severe preeclampsia. So we have this basic preeclampsia profile, which we all do, and I don't want to go into the details, but more importantly, which I found very, very useful in patients with obesity is, of course, a 12-lead ECG. Echo is mandatory in our hospital in all patients with BMI of more than 35. And I do ABG with lactate in all patients who have underlying preeclampsia or even obesity with BMI of more than 40, because we have seen, I would say at least about 7 to 8% of women, they have basin hypercapnia because of sleep apnea. They may not be symptomatic, but if you do an ABG, we see PSU of almost about 38 to 40. If we know that in pregnancy, the normal PSU is around 28 to 32. So anything more than 35 is impending respiratory failure, and more than 40 is respiratory failure. So we have seen that pH of 7.4, PSU of 40. So well compensated respiratory acidosis, which again indicates a OSA, presence of OSA. So all these things we need to look into this: CADs, OSs, and perioperative risk of DVT. Depressive psychosis is very common. At least I remember 2 suicides in our hospital last 25 years. Attempted suicides, of course, survived, patients survived. But all these things have to be kept in mind. And sleep apnea, of course, the stop bank score and all those things we all know. I don't want to go into the details, but see that you assess the respiratory capacity of these patients very, very well. Because patients with even they may not have obstructive sleep apnea or snoring, but they may have endothelial dysfunction and edema that can compromise perioperative period. Because even with little fentanyl intrathecal or neuraxial morphine, sometimes they may go into severe respiratory depression. Not very common, but not unheard of. Pickwickian syndrome is an extreme form of obesity in pregnancy. Alveolar hypoventilation is common, somnolence perioperative is common, and we need to look for all these problems which can happen. Of course, we don't see these magnitude, fortunately, because of their young age, but you need to keep this in mind. And hence, perioperative or preoperative echo, one detailed echo is mandatory, especially in all obese children with BMI of more than 35 and 40, especially if they have underlying hypertensive disorders in pregnancy. Discuss with the family, be candid, be candid. There is nothing hiding beyond it, because it is always better to have a clear discussions, what to expect from us, what are your plans, and what are the likely complications. So increased risk of surgical site infections, hemorrhage, urosepsis, worsening of OSS, post-operative pulmonary complications, embolism, all those things have to be mentioned, because we know that anesthetic complications in the perioperative period can be lost airways, failed intubations, aspirations, respiratory failures. In fact, there have been cases where aspiration and ECMO also have been put on these obese patients. And importantly, you counsel them extensively for regional, and when the day comes, T-day comes, regional is an absolute contraindication because of the changed dynamic pathophysiology. So you need to keep this in mind and accordingly counsel all these patients properly. Airway and preeclamptics, airway and obesity, we all know it's a physiologically compromised airway, anatomically challenging airway, and it's a perfect cocktail for disaster, airway disaster. And we need to have plan A, plan B, plan C for difficult intubations, and all those drills that you need to have clearly laid out before you step the patient into the theater. As I said, head-to-toe echo, especially ONSDs and preeclampsia, is very useful. Dr. Jay Shisud, I was glad that she mentioned as a routine. We also do in robotic as a routine ONSDs. But yes, in preeclampsia also ONSD is a very, very useful indices, especially before extubation. If the edema increases, then it's a thing that you need to electively ventilate this patients. I was telling a little while about the role of ABG in preeclampsia. I'm sorry, a little breathless, but I'll manage. This patient, like basically patients when they have severe preeclampsia, the incidence of metabolic acidosis is very, very common. And this was a patient who had a severe preeclampsia, came with a pH of 7.01. And the decision to terminate the pregnancy has to be taken rightly. Because if you don't decide and wait on this patient, they'll end up with acute kidney injuries, acute tubular necrosis, acute kidney failure. And at least I remember last 25 years, we have had 7 patients who came with normal renal functions at conception and ended up with renal transplant by cortical necrosis. So follow up these patients, and ABG is one tool which I feel is a very, very important tool, especially if the patient has underlying severe preeclampsia, because presence of metabolic acidosis, if you terminate the pregnancy at the right time, you can reverse the pathophysiology. So this is the change we see. We admitted the patient at 10 p.m. in the night, 22, and the next day morning, everything back to normal. So if you wait on this, patient's fetal parameters are stable. If you wait for another 12 hours, they go in for hyperkalemia and acute tubular necrosis. So planning safe anesthesia is very, very important. And when I say safe anesthesia, it has to be plan A, plan B, and plan C, not just stick to plan A. So obviously my plan A is spinal and plan B also is spinal. Then can't I give a combined spinal epidural? If my plan C also is spinal, then can't I give a continuous spinal? Or if it's a difficult back, let me have an experienced hand. Very, very important. Certain special techniques are also have been mentioned in the literature. I don't recommend, we don't practice, like double catheter techniques, where especially patients with BMI of more than 70, they have given thoracic epidural for post-operative pulmonary complication prevention and lumbar epidural for intraoperative analgesia. like a CSCF for intraoperative and thoracic epidural for postoperative pulmonary complications. But generally, we have circumvented most of these patients. Like the highest BMI I have anesthetized 87, and we could circumvent with a simple combined spinal epidural technique. Intubation, extubation plan has to be very, very meticulous, and drugs and dosages have to be laid out without any ambiguity. More importantly, what are the likely unanticipated perioperative events that you're likely to encounter has to be meticulously charted out, planned, and the management also appropriately discussed. Like suppose if I'm giving oxytocin, suddenly patient develops pulmonary edema, patient desaturates, what is my plan? Okay, I need to have 1, 2, 3, 4, 5. If this patient develops postpartum hemorrhage, she's an asthmatic. Asthmatic or corporation contraindicated, methogenous contraindicated, what to do. So those ambiguities should not persist. So likely unanticipated perioperative events has to be planned. Is one of the patient which gives a lot of issues. You can see the pannus, thick pannus in the lower abdominal wall, a perfect cocktail for surgical site infections. So you need to have a surgical site preparation starting at least 48 hours before surgery so that they take meticulous bath, antifungals, antibiotics, antifungals and soap water is what is required, or sometimes a sterile bubble bath with chlorhexidine is what is required. But more importantly, the thing which I want to emphasize is CVP is very, very erroneous when it comes to obesity, especially with severe preeclampsia. You see the patient with even a wedge of the 15 degrees and above with a right tilt, the CVP is 33. But you see this, we have a nasal capnography, but CTCO is going up as the surgery is progressing. And we did a blood gas. If you see blood gas, the PSO is almost going up to 54.7. And this is where you land up in intraoperative problem because you're giving 100% oxygen to the vein circuit or the Hudson mask. SATs are well maintained, but this patient, they're going for hypoventilation intraoperatively. So you have to be very judicious with what narcotics and what level of spinal you want to achieve, what drug you want to achieve. There have been a lot of instances where they say that the drug dosages for regional anesthesia in obese parturient, morbidly obese parturient has to be reduced. And there have been incidences where even the CSF volume on MRI has been thought to be reduced in obese parturient. But the consistency of dosage reduction in regular drugs in obese parturient there is no consensus. Generally, what we do in our hospital is 10 milligrams of hyperbaric bupivacaine, 20 mg of fentanyl is what we give. We avoid neuraxin morphine in morbidly obese patient with OSA. And importantly, when the patient lands up with desaturation, you need to be ready with your armamentarium. And generally, we won't be able to give an IV through the anesthesia workstation, even though it's a advanced anesthesia workstation. So we generally procure by default ICU ventilator in the theater so that in case if the patient desaturates or becomes hypercarbic or somnolent intraoperatively, straight away without disturbing the surgical team, you do your work from your side and stabilize the patient ASAP. So unanticipated event management and planning is very, very important in your practice. This is what I have learned from my experience last 25 years in obese parturient. As far as anesthesia, labor anesthesia is concerned, most of, at least I would say, 60% the land of cesarean section, but 40% they do deliver normally. So you need to have a planning, meticulous planning for labor anesthesia as well. And generally, we have a tendency of putting early epidural in labor before we call off our date, especially if you have a high-risk parturient. Again, early epidural means early fallout. And when the peak action takes place, epidural catheter may fall out. So you need to be careful how you fix the catheter, how you want catheter to be fixed. And generally, the technique of choice in our hospital is for labor anesthesia is simple, continuous lumbar epidural. But yes, if the landmarks are going to be very difficult and then identification is going to be difficult, yes, we have a low threshold to use neuraxial ultrasound and identify the space and the depth and the length of the needle and go for a combined spinal epidural technique or a DPE, a dual pinch epidural technique, so that we know that epidural is going to work or epidural is going to work when it's going to get activated. We don't practice continuous spinal analgesia for labor analgesia in our hospital, and single shot spinal for labor analgesia we do not practice in obese unless she is about to deliver, which is very, very rare. But yes, the lumbar epidural is the technique of choice, followed by continuous combined spinal epidural analgesia. And just we give neuraxial fentanyl if at all. Otherwise, just identify the space and be happy that your catheter is in the epidural space that is working properly. If this patient comes for cesarean section, categorize. Always have develop a close rapport with the obstetricians team and categorize cesarean sections. Generally, most of these obese patients are category 2 and category 3 sections, but at least a small chunk, I would say 3 to 4%, they land up with stat cesarean section. If it's stat cesarean section, morbidly obese, it's going to be hell lot of a noise, high decibel environment in the theater. So you need to see that everything is in place before the patient goes, and it has to be protocolized. You just that one can't have a stat section drill. So stat section drill has to go on a continuous basis in your hospital. So the technique of choice for cesarean section in our hospital, of course, is single shot spinal, combined spinal epidural, and epidural anesthesia. Only those patients who come from labor anesthesia for conversion to cesarean section, and we have a protocol to minimize failures for conversion also. Continuous spinal analgesia, we don't practice routinely, as I said, because the incidence of neuropraxic injury is quite high, and we don't have a standardized spinal catheter kit, quite expensive. Intentional dural puncture anesthesia is one thing sometimes we practice, especially intentional lumbar intrathecal puncture, especially when the landmarks are very, very poor. But again, if you ask me how frequently do we do, probably I have done probably last 25 years, 3 or 4 cases where we have intentionally punctured the dura and gave anesthesia just to minimize any inadvertent, because we couldn't look at the epidural space properly, and we could get a CSF tap intentionally. Double catheter technique we don't practice, but there are a lot of case reports, especially Dr. Ashraf Habib from Duke Medical School. He has published quite a few publications on double catheter technique, where they use L2, L3 for lumbar CACA, and then D9, D10, or D11, D12 for thoracic epidural for post-operative pulmonary complication prevention. But my own experience of probably more than, I would say, 5,000 cases in the obese parturian, hardly there is a need if you give a good CACA block at L2, L3, or L3, L4 with a catheter threaded of 4 to 5 centimeters cephalad, we can circumvent this DCTs easily. Now, of course, most importantly, not to undermine a combined, general neurological anesthesia pathway has to be very meticulously laid down. A word about subdural placement of epidural catheter, especially when you're giving intentional dural puncture or dural puncture epidural technique, or multiple attempts because of difficult regional. This is an electron microscopic picture where you can see the epidural catheter in the subdural space. Epidural catheter in the subdural space, and there's the dura subdural space. This is CSF. So when the catheter in the subdural space, it can become erratic. It can have a cephalad spread. Patient can have respiratory arrest. So whenever you are doing international dural puncture technique or a dural puncture epidural analgesia or multiple attempts, see that you enter into the subarachnoid space completely, the Q needle, and then thread the catheter, so that the catheter should be in the intrathecal compartment or in the subdural compartment. Recent past, last 2 decades, there have been 2 good impacts. Difficult airway management has not become mandatory in pregnancy, thanks to propagation of different varieties of regional anesthesia, different types of needles, different types of medications, adjuvants, and regional anesthesia is almost about 17 times safer compared to general anesthesia. Availability of different supraglottic airway devices, the 2nd generation, 3rd generation devices with high ceiling pressures, have made our job very, very easy. Importantly, the guidelines from our Association of Obstetric Anesthesia on difficult airway, the guidelines of AIDA guidelines, Difficult Airway Society of India guidelines, and DAS guidelines from UK, more or less they overlap in their local distribution and local needs, but they have made airway management in an obese parturian very, very safe. And I recommend that all people practice general anesthesia or anesthetic technique have to by heart this guideline, so that there is no ambiguity when you have plan A or plan B or plan C is necessary. Because when you talk about regional, you need to have a proper length needle, otherwise maybe not be able to reach the epidural space. But having said last 25 years, how frequently do I use long needles? If you ask me, the requirement of long needles probably is 1 or 2 a year, not very high, very high. But having said that, you need to have availability of long needles in your armamentarium. And as I said, techniques, yes, it's a combined spinal epidural technique or a single shot spinal or loss of resistance to saline, not air. And importantly, continuous spinal, we don't use, as I said, but it is very important that you have every damn thing in your hospital, in your unit, so that when there is a need, you can use appropriately. Identification of midline, again, sometimes is very difficult in obese parturient. Sometimes they may have tattoos in the midlines that can help you. Other best thing is I draw a line from the nape of the neck to the natal cleft, or the patient themselves can identify the mid spine and then for you, because they know where their spine is. So, and of course, ultrasound, gold standard. Ultrasound is the gold standard, but have a low threshold to use ultrasound for neuraxial imaging in obese parturient. As I said earlier, the incidence C-section rate is very high, and we need to have a proper meticulous planning about which space, what depth, and other things. And if you look at the failure rate of epidural analysis, I was taking almost the literature mentioned the failure rate up to 20% morbidly obese. Fortunately, in our team, the incidence of failed epidural-led conversion from labor epidural to cesarean section is less than 5%, which is acceptable. So this is what I was talking about. When you put an epidural early in labor, you need to remember that catheter can migrate in, migrate out. Catheter may not work when it is needed. So you need to have everything in your armamentarium, different types of needles, so that it becomes easy for you to identify. And this is what I was talking about, the extra length needle, 12 centimeters, 14 centimeters. And we have several companies that come up and help you out with this extra length needles. Meticulous fixation of catheter is of paramount importance again, because I don't want my catheter to come out at the peak action of anticoagulation, because most of these patients will be on postoperative thromboprophylaxis. And after giving enoxaparin, within 2 hours or 4 hours, I don't want my catheter to come out. So catheter fixation has to be done properly, and it has to come out at when you want. Very, very important. And low platelets, generally we have a threshold of putting epidural for safety if it is platelets more than 75,000. But if it is less than 75,000, then single shot spinal is preferred. The incidence of neuraxial hematoma is very, very rare, fortunately. But again, you need to weigh risk versus benefit. What is the risk of difficult multiple attempts, neuraxial hematoma, versus risk of difficult airway and intubation? So you need to have a risk versus benefit analysis. And generally, point of care testing also sometimes is quite helpful. Generally, what we do is to minimize incidence of neuraxial hematomas. We have innovated our own technique, CSF technique, continuous saline flush technique, wherein we thread the catheter, flushing the catheter as we thread the catheter, so that we can minimize the bloody taps. Like once you epidural needle is in the TUA needle is in the epidural space, we connect the catheter to the saline filled syringe and try flushing the syringe as you advance the catheter. So whatever comes in front of the catheter, it's deflected away, and minimizing blood tap is very, very common, and you can minimize the neuraxial hematomas as presumably. Fortunately, in obesity, incidence of hypotension is rare or less common, especially if they are underlying preeclampsia. But as a protocol, we don't treat hypotension, we prevent hypotension. So phenylephrine 100 micrograms bolus is mandatory along with co-load. We don't wait for the hypotension to occur and then treat. We prevent it. And there are a lot of studies which say that prevention is better than treatment of hypertension. When it comes to general anesthesia in obese, it is, as I said, airway is a very dynamic process in obstetrics. It changes in every trimester. It changes in labor. It changes during first stage and second stage of labor. So Mallampati grade 1 can become grade 3 to grade 4 during third trimester, and Mallampati grade 2 in labor can become grade 4 at the end of labor. So assessment is very, very important. Like this was a patient, you can see the engorgement of nasal mucosa. Don't even dare to put a nasopharyngeal airway in these patients. You may bleed into death. This was a patient with Mallampati grade 1, had a seizure, large buccal hematoma, sublingual hematoma, hardly any trismus. So Mallampati grade becoming Mallampati 4 just with one seizure, obese parturient. So you need to have a very dynamic assessment of airway assessed during PAC, airway assessed before surgery, airway assessed before induction is very, very important. The gastric residual volume is quite high, so risk of aspirin prophylaxis has to be prevented. Anticipate difficult mask ventilation, and importantly, difficult intubation. As I said earlier, they are physiologically anatomically challenging airways, and they are moribund patients, especially if they have severe preeclampsia, BP of 220, 120, and they have sometimes pulmonary edema. So they have already VQ a large physiological shunt with hypoxemia. So generally what we do is we suppress the laryngosympathetic response with using dexmedetomidine. We start infusion dexmedetomidine at least 30 minutes before 0.5 max per loading dose, and then it helps wonderfully, no respiratory depression, and also give 2 grams of loading dose of magnesium to suppress the laryngosympathetic response. As far as possible, try to avoid fentanyl so that we can mitigate neonatal respiratory depression. But if necessary, yes, don't hesitate to give fentanyl. Inform your neonatologist, and low threshold to use nitroglycerin IV labetalol. A word of caution about IV labetalol. Many a times, despite echo being done a couple of weeks before, some of these patients, hypertension, especially severe accelerated hypertension, they develop compromised LV function perioperative period, peripartum period. And the moment you give a patient delivers, they develop pulmonary edema. So IV labetalol is a negative. We know that chronotropic and sometimes can cause myocardial depression and can potentiate pulmonary edema. So generally, the drug of choice which we use or recommend is dexmedetomidine, magnesium sulfate, fentanyl, NTG. And of course, if rate is very high, then of course use IV labetalol as well. Risk of atelectasis with apnea is very common, especially obese posture, despite propped up tilt and left uterine displacement and weak homogeneity. So pre-oxygenation of paramount importance. A lot of techniques have been mentioned. And the technique that we generally follow is we give CPAP for all patients who require intraoperative intubation, obese parturient. Either we use Thrive or we use CPAP to recruit the lung at induction, and conventional technique may not help much. HFNC is very useful. Yes, it's a fantastic device that has come off later now. This COVID pandemic has helped us. Most of the hospitals to procure HFNCs in their ICUs, and they can pull that into their operating room also. See that you maintain good flows, and we always practice modified rapid sequence intubation. I don't recommend rapid sequence intubation at all. I repeat, in my unit, I don't recommend rapid sequence intubation. I always recommend modified rapid sequence intubation, wherein we give a sleeping dose of induction agent like propofol, then put a oropharyngeal airway, and then once reflexes are suppressed, succinylcholine, and gently ventilate for 60 seconds. We gently ventilate for 60 seconds. We don't maintain apnea, so that you can keep recruiting the lungs and keep oxygenation. Very, very important. And if you feel slightest difficulty in laryngoscopy, and we use video laryngoscope straight away, but if there is difficulty, we have a very low threshold to use ProSeal LMA or intubating LMA, which is there immediately and decompress the stomach. And of course, routine PP, all those things are taken care of. But it's very, very important that you practice modified rapid sequence intubation. Apneic oxygenation, diffusion respiration, eventually mass flows, all these things have been studied even in pregnancy, and they have obtained an apnea period in parturient, obese parturient, almost for 16 minutes apnea without significant desaturation. So all these thrives are quite significant. They are quite helpful. And if you see, this is what one of the patient saturations, and at the end of 60 seconds, despite modified rapid sequence, is desaturated. I mean, of course, this was HFNC. And at intubation, the sats fell to 91%. But fortunately, 2 of us could manage successfully intubation. But if you see the number of people they require for Foley's catheterization, there are 4 people. So these are the problems that are there on both the sides, either sides. Difficult insertion of Foley's, difficult insertion of tube. And this is why the patient, they desaturate very rapidly during induction intubation. This is a ramp that we have innovated locally, hardly costs about 4,000 rupees, but it helps us tremendously. And when the patient is on the ramp, automatically we know that the tragus and the sternal notch distance and the head extension is good, and laryngoscopy becomes little easy. Again, appropriate size table is very, very important, because many a times if you don't plan, this was one of the old cases, going back to early 2000. This was a lady with BMF almost about 58, and intraoperative, the drum of the table broke, and you can see the oil spillage on the table. Fortunately, it just table went down by 1 foot. Nothing happened to anybody. Patient was safe. But this was a patient, the weight bearing capacity of this table was almost hardly just about 150 kilos, I think. And we didn't, this was the early days. So you have to keep in mind, meticulous planning has to go on. So planning safe anesthesia, and not only the drugs and this thing, but also the infrastructure management. Surgical prophylaxis is very important. Oxytocin, again, PPH prevention is very important, but don't overdose oxytocin, because we know that they are prone for pulmonary edemas. postpartum hemorrhage protocol should be there in place, because PPH is common in obese, and restrictive fluid therapy. Yes, don't overload the patient, because these are the elective. Most of them are come as elective, and your fasting is 6 hours before, and you can start. ERAS protocol is for all, so within 2 hours they are on up and about and liquids. But importantly, in obese GA, especially anticipate slow recovery, extubate fully awake, and see that they are postoperatively monitored in ICU. A word about colloid-oncotic pressures. We know that colloid-oncotic pressure is reduced in pregnancy. The non-pregnancy is about 27, but in pregnancy it may go up to 15 millimeters of mercury postoperatively. And there's a low oncotic pressure. These changes are exaggerated if the patient has severe preeclampsia or chronic hypertension with superimposed preeclampsia, and they are prone for pulmonary edema. So as I said, unanticipated management of problems is very, very important in the commonest is pulmonary edema. So have non-invasive ventilation by the side in OT, or if you have a ICS machine or a high-end machine, should not be an issue, but see that they're easily available. Extubation has to be meticulously planned as intubation. Recruitment before extubation is mandatory, so that the basal lactic tests, lungs are all opened up, alveolar opened up. Magnesium sulfate, especially if they are on magnesium sulfate therapy, continue, do not stop, but titrate your muscle relaxant accordingly, so that you don't overdo, and have a low threshold to electively ventilate this patient if the patient doesn't have adequate recovery from neuromuscular blocking agent. Extubate converts conservatively, fully awake, propped up position. Laryngosympathetic response at extubation also is of paramount importance. And importantly, if the patient has OSA, post-extubation obstruction is very, very important. And as Dr. Jayesh rightly pointed out, do a leak test. Do a leak test, very, very important. If the patient has airway edema, pupillary, check the pupillary size. If the airway edema, do a video laryngoscopy again. If the glottis is good, extubate. Otherwise, have a low threshold to electively ventilate or exchange over a put in LMA, or if you feel okay, not too bad, connect an IV immediately post extubation. So these are the things that have to be planned meticulously. Most of the post-operative area complications occur at extubation. Aspiration risk is more, desaturation risk is more, and importantly, reintubation after extubation again is going to be disastrous, and sometimes you may lead to severe LV dysfunction or negative pressure pulmonary edema. So all these things can be meticulously avoided if planned properly, executed properly. Multimodal analgesia again is the norm. Avoid NSAIDs. We give tab block liberally, but having said that, tab block acts hardly 10 to 12 hours or less than 15 hours. But yes, something is better than nothing. But see that you avoid NSAIDs, because most of these patients are on heparin. They have a neuraxial catheter, and you need to be careful so that you can avoid any neuraxial issues with regard to neuraxial hematomas, which are though very, very rare. Monitor for hypoxia and hypoventilation, very, very common. Again, so you put them on ERAS protocol, early ambulation, spirometric exercises, and see that they go to the physiotherapy unit in the hospital, or at least they're up and about ASAP. DVT prophylaxis, and as a protocol, we continue for 7 days in our hospital. Generally, the weight of the patient is the BMI. If the weight is more than 100, we give 60. If the weight is less than 100, we give 40 milligrams OD. But 60 milligrams, 40 BD or 60 BD also sometimes can be given, especially if the patient has several, depends on the other risk factors, like as per the RCOG guidelines. But our hospital, we give about 5 to 7 days of DVT prophylaxis. Generally, prophylaxis is OD. Generally is OD. And all these obese parturients on the day 1 or day 2, we keep them for at least 24 hours in the ICU or HDI dependency unit, and subsequently they are going to step down unit, and see that they are under the surveillance and the radar of the perioperative team. Anesthesia people, they see daily for at least 2 to 3 days to monitor for any atelectasis or postoperative pulmonary issues. And because sometimes silent aspirations can happen despite regional anesthesia, you need to identify them early before the patient crashes, and have a low threshold for radiological evaluation, especially chest exercise or lung ultrasound. Beware of the patient with obese parturient with hoarseness. Hoarseness means involvement of laryngeal nerve, involvement of supracortic edema, and the narrowest airway I have seen in my obstetric practice is 3.5 to 4 millimeters airway. This patient was a 107 kilo patient with severe preeclampsia, complaint of hoarseness. She came in labor. We got an ENT consult done, and the glottic opening was 3.54 millimeters. For unforeseen reason, if you land up in midnight GA, it is impossible intubation, impossible ventilation, and it's a perfect recipe for airway disaster. So any parturient with change of voice, altered airway or this thing, you have to be very, very, very cautious. Well, this case is not in conjunct to obese, but I thought this was a very good case for near miss hypertensive spectrum. This was a lady with BMI of almost about 34 or 35, not very obese. Normotensive all throughout, mildly proteinuric, admitted to ICU with severe headache in view of imminent eclampsia. GCS was 15, and obstetric team decides for emergency cesarean section. And they said, "Sir, cesarean karna hai, jaldi kar dijiye," because patient was having fleeting headache, so severe headache, like dying. When I said GCS is 15 people, I asked them to, before jumping for spinal or GA, I said, let us assess the patient. We assess the patient. If you see, she was having lateral rectus palsy, 6th nerve palsy. And I said, okay, mildly obese, hypertension 130, 90, not a great, the reflexes are normal, everything is fine. Pupils are normal, GCS is 15. Let us do a fetal assessment. If fetal assessment is fine, I would like to evaluate for lateral rectus palsy. And luckily, lateral rectus palsy was evaluated. It was a category 2 cesarean section. We didn't rush the patient to the theater. But this is what we have found. This was a patient who was shot by her husband. It was a homicide. Patient was shot through the nostril with the bullet, country bullet, and there was a bullet in the brain. And of course, we did a midnight cesarean section with emergency craniotomy and cesarean section both. So the thing that I want to highlight is when you have a parturient with headache, blood pressure, severe headache, it is just not one entity. You need to see the patient as a whole. And this is where history taking, talking to the attendants, talking to the family, any suspicion, all these things have to be, this is one out case, but yes, I keep citing this case very frequently because we identified the problem and we could salvage both the mother, baby and the family. We could prevent divorce in this case with social support. So the take home message is obesity and parturient. Never attempt this patient in periphery. Shift the patient to a higher institute where you have good airway backup, good ICU backup. Never attempt alone. Always call for help. Experience. When I say help, experienced hand, because experienced hand is very, very important. Informed consent is very important, so that you lay down all the plan A, plan B, plan C medications to be given. Regional anesthesia, of course, has excellent safety record, but GA is a backup for all, and you need to be prepared for GA. So if at all you have any problem, call for help early rather than late. Effective communication is very, very important when you deal with high-risk obstetrics, especially obese and comorbidities. And we started this process of safe handover protocol as per this. This was a beautiful article that came in IJOA probably in 2012 or 2011, I don't remember exactly. But safe handover is nothing but sick ICU patients in obstetric unit and at risk for major hemorrhage in a hospital, follow-ups and epidurals. Because these are the 4 things that we do in our hospital. Sick patient, we have 24/7 obstetric critical care. We have 24/7 epidural services and follow-up of patients post PDPA, post back care, all those things. And if you see, this is where we hand over the night's proceedings to the daytime. Like this is a patient where you have BMI 46, GDM, blood pressure, airway grade 2, spine grade 3, presently in labor room 4, 3 centimeters dilated, counsel for early epidural, wishes to wait. So this is exactly what we want. A good effective communication has to happen between the shifts, between the team. Very, very important. Again, if you look at the WhatsApp chat, social media definitely has helped us to plug in certain communication issues. This was the lady who requested only female anesthetist. Sometimes this demand is not common in Hyderabad. And spine grade 3 airway is okay, not willing for LA even after counseling, no pains yet, ongoing IUL, induction of labor. So this communication helps us to know and titrate the patient throughout the night, however, especially the on-call person it becomes very, very easy. So this is what I thought communication is very, very important. This was one of the papers that we published or rather presented in which is an award-winning paper, retrospective analysis or rather a prospective study of 1,032 obese patients. And if you look at the incidence of comorbidities in these patients, if you see statistical significance, hypertensive disorders, statistical significance, GDMs, Postpartum hemorrhage, statistical significant, and duration of surgery in minutes, statistical significant. So long surgeries, long duration surgeries, preterm deliveries, importantly, neonatal respiratory distress. So we want to avoid anything that compromises the neonatal outcome also during our meticulous planning. But importantly, when it comes to anesthetic complications and technical hitches, if you see technical difficulty also is statistically significant. Spinal attempt more than 3, significant. Repeated spinal, significant. So whenever you're giving repeat spinal, you want to give a repeat dose, same dose, you want to give half the dose, you want to give 1/4 the dose. So all these things have to be meticulously charted. And when I say a half dose or 1 dose or 1/4 the dose, I need to define my fail block that has happened in the primary technique, or would I have avoided fail block. So all these things we could, over the years, we could, with our own data and our own audit, we could overcome most of our hitches in managing obese parturient. And this is one of my favorite slide. I always keep projecting in most of my presentations, our dashboard audit that, in fact, we started clinical audit in anesthesia in 1997. And we have been upgrading the quality of audits in our hospital. And this dashboard, we started in 2011. And in 2012, if I remember, we published this in SOAP, which got the best paper award. And it got published in our IGA also. So basically, this is an obstetric anesthesia dashboard audit where you lay down perioperative or peripartum complications, anesthesia, and our idea is to go green. We should not see any red or orange. And if it are any orange or red, we have to get alert and you need to modify and introspect and upgrade your regime. Thanks to Ganesh Chaudhary, our cartoonist from Sholapur. This was the article, I think, cartoon he published in 2016 before Olympics. And well, this is not certainly the way you need to go for obese parturient to give anesthesia for obese parturient. Definitely not. So to conclude, I would say that obese parturient definitely is a lifetime bomb. Very dynamic situation can happen in compromising airway or difficult regional, or regional can be an absolute contraindication in a patient when the regional was counseled. So see that you categorize this incidence section properly, metal stabilization has to be done properly, and importantly, see that if at all you are giving early epidural, the catheter should not migrate, it works at the time of need. Video laryngoscopes, ultrasound guided uniaxial block, long needles, experienced hands, meticulous planning, plan A, plan B, plan C, extubation plan, intubation plan, pre-oxygenation plan. Everything has to be played, including drugs and dosage regime. Thank you very much.
Oh, thank you, Dr. Sunil, for your excellent talk. Now, and also the practical tips and your experience in sharing the airway management as well as the neuroaxial blocks in the parturient obese patients. Now I invite my other co-chairperson, Dr. Sukanya Mitra, to take over the session for the chatting questions, chat questions. Dr. Sukanya, please.
Thank you, Dr. Sunil. That was an excellent lecture. And it was really practical. At the same time, you such useful practical tips. I'm sure all the participants are greatly benefited. So I think you have really made us aware that PAC has a role, a definite role in preventing all the catastrophe, and meticulous planning is, of course, the need of the day. And definitely communication and audit, they are two very important things. And this is very important learning point for our juniors. The audit is very important. So I see some interesting questions in the chat box. So one of the participants asked that what is the concentration of the drug that you are using for morbidly parturients when you are instituting labor analgesia?
The concentration of drug doesn't change. In fact, we use low dose mixtures and ultra low dose mixtures. And we have been very comfortable using bupivacaine with fentanyl and subsequently levobupivacaine with fentanyl. And now we are using routinely ropivacaine with fentanyl. And the dosage regime, we start with about 15 to 20 ml of 0.08% of ropivacaine and 0.1%. We go up to 0.1% ropin the second stage of labor, or maximum 0.125%. So the dosage, the concentration of ropivacaine doesn't change in obese. It's a volume-based block. And generally, the volume that we give is about 15 ml, 12 ml to 20 ml, depending on the level and the height and the other parameters. But majority of the time, it is low-dose mixture of ropivacaine with fentanyl currently. Earlier, we are using bupivacaine. We are comfortable with bupivacaine also, but the market demand and this thing, juniors are more comfortable with ropivacaine. Why not let us have ropivacaine? Yes.
That's what Dr. Pandya has to say. And then there is another interesting question. You have touched upon it, but one of the participants wants to know what is the role of dexmedetomidine in this patient.
Yeah,
if you
see,
could then repeat it for the house.
Yeah, see, the dexmedetomidine is a wonderful drug, especially when the patient has underlying severe preeclampsia, because the laryngosympathetic response to intubation, despite propofol and fentanyl, sometimes see fentanyl generally, if you want to give a good laryngosympathetic response, the dosage, recommended dosage for fentanyl is almost about 2.5 to 3 micrograms per kg. Generally, even in a normal healthy parturient, 3 micrograms per kg, we have not seen any neonatal respiratory depression. But here we are talking of a patient who is sick, obese, preeclamptic, preterm baby with compromised uteroplacental blood flow. So we don't want to contribute any neonatal morbidity by giving more fentanyl. And what we have realized is, yes, dexmedetomidine is an off-label drug. It has not been recommended by the standard literature, like LMWH also has not been recommended by FDA in like fondaparinux and all those things have not been recommended, but they've been used anecdotally. And I got this data of using dexmedetomidine because our neonatologists in NICU, they use dexmedetomidine quite liberally in newborns who require ventilator support. Earlier, they were using morphine, and they switched over to dexmedetomidine. Then they are using the newborn for elective sick babies ventilation. Why don't we use antepartum for prevention of laryngosympathetic response? And generally, we give 0.5 mg per kg loading dose starting about 20 minutes before. Over 20 minutes, it suppresses sympathetic response so beautifully that even little propofol, just 100 milligrams, and then suxamethonium, hardly you see any laryngosympathetic response. Otherwise, the BP just shoots up to 200, 220, and we don't know what happens intraoperatively, and you may end up with intracranial bleeds. So dexmedetomidine generally 0.5 to 0.7 mg per kg over 20 minutes is what we start before induction, if there is a time, of course. As I said, categorization section is very important. And then 2 grams of loading dose, or 2 grams of magnesium also we give over 2 minutes before induction. So that effectively these two combination helps us cardiovascular stability. Because we have seen that IV labetalol again is an excellent drug in controlling blood pressure as well as rate, but we have seen intraoperative pulmonary edema is very high. And subsequently, when we did postoperative echo, ejection fraction, which was normal 55, 67, 65%, it dropped to 45, 35 to 40% postoperatively. So a small chunk of hypertensive parturient, they do develop perioperative LVF because of accident hypertension, pulmonary edema. And labetalol sometimes can be dicey in this setting. So a combination of dexmedetomidine with labetalol, with magnesium, we have found it very, very useful. And same thing we use at extubation also. NTG also we use it, but NTG, what happens, it causes tachycardia. And sometimes it can cause profound fall in hypertension because especially, as I said, preeclampsia is one of the commonest deterrent in obese parturient, and they are a vasoconstrictive patient. The moment you give a little NTG, the blood pressure may just drop to 90s and 100s and 110, which is not desirable. So that way, again, dexmedetomidine and magnesium sulfate is a fantastic combination.
Okay, thank you. I think the doubts has been clear. So there was another question also for you. Do you use isobaric solution in obese patients?
We use hyperbaric.
Okay.
Can
So,
we now, please, because we have to running short of time. I'm sorry.
I think there is a last question that I think we can finish with that. You mentioned about the length of the 12 centimeters, 14 centimeters. Somebody want to, what is the length of the epidural needle that would be using?
See, the length, the conventional TUA needle, I don't have, again, conflict of interest again in industry, but the standard thing that we use is 8 centimeters length of hub, which is more than sufficient in, I would say, about 92% of cases. 8%, you may require 9 centimeters needle, which is V's needle, which is again available other companies there. extra length is enough. But 12 centimeters, as I said, probably once or twice a year, hardly we use it. But having said that, we keep all these needles because we don't know when the rainy day is going to come. So rather than hanky-panky, it's better to have extra long needles, and you can autoclave them, or you can ETO them and keep it for another 3 years. You can extend the shelf life, not an issue. But having said that, it is available and they can be used. But they don't require. Most of the time, 8 and 9 centimeters needle suffices.
Can we end here, sir?
Absolutely,
Yeah,
madam.
rightly said. Yes, madam, just concluding statement. I think Dr. Pandya, you are absolutely right. Planning is very important when we are dealing with such patients. And I think there are many more questions in the mind of the participants, but we can address them at the end of the session. Thank you very much once again for the wonderful talk. I hand over the mic to Dr. Rekha Das to continue with the program. Thank you.
Thank you, Pandya sir. This has been a wonderful topic and a very, very interesting topic, and a topic at large interest to many people. And I am sure there will be many more questions to you that will come up. And I think this needs to be covered more extensively later on.
Thank you. Thank you.
So, thank you, sir, once again. And thank you, our chairperson, Dr. Basant sir and Dr. Sukanya. Now we move over to our last topic, which is regional anesthesia and laparoscopy feasibility and safety by Dr. Natasha Mishra. And this topic will be chaired by Professor Vandana Mangal, who is a senior professor of anesthesia at SMS Medical College, Jaipur. And she was, if you remember, she was the scientific chairperson of 2015 at Jaipur, ISACON. And with her, the co-chair will be Dr. Kalyani Bala Naik, who is a senior experienced anesthetist and an associate professor from SCB Medical College, Cuttack. With this, I would request Dr. Vandana Mangal to kindly introduce our speaker. Thank you. Madam, please unmute yourself. Madam, please unmute yourself.
Yeah. Good evening, everyone. Thank you, Dr. Rekha Das, for giving me this opportunity to attend and chair this particular session. And I thank Dr. S.P. Sharma Saab, the president, and Dr. Naveen Malhotra, and the executive for that. Now, without much ado, I would like to introduce Dr. Natasha Mishra. After having heard two stalwarts of specialty, we are going to hear to a young budding anesthesiologist, a very promising anesthesiologist who's done her post-graduation from none less than PGI Chandigarh. She was groomed there in 2011, and then she did her DM in neuroanesthesia from All India Institute of Medical Sciences, New Delhi in 2017. She has varied interest in neurotrauma, neuroanesthesia, neurocritical care, and pediatric anesthesia. Today, I think I should not waste any more time and listen to this young budding anesthesiologist. Natasha, there's still about 140 people waiting to listen to you. So over to you, Natasha.
Good evening. Thank you, Vandana ma'am, sweet introduction. But yeah, I'll just quickly share my. Yeah, is it visible?
No, you are not visible, Natasha. Thank you.
Okay. Are my slides visible, ma'am?
Yes,
yes. Everything is audible and visible.
Yeah. Okay. Hey, everybody, and special thankful. I'm very much thankful to Dr. Rekha for providing opportunity in the actual gurus we have in our country, and it was actually a experience to listen to all the speakers. So thank you all. Quickly begin the topic provided to me, and today we are going to discuss on the safe regional anesthesia laparoscopic surgeries. And as we all know that laparoscopy has been, touted as the most promising modality of the surgery since last more than 50 years, with benefit like lesser amount of pain, lesser amount of post-operative complications, less tissue damage, faster recovery, increased safety, and obviously cosmetically. But the problem is nobody talks about or nobody talks about that which method of anesthesia should be used as the best technique, or rather the best, but should we use only one technique of anesthesia to for our patient, or should we tailor it according to the need of the patient, need of the surgeon, and most importantly according to the need of the anesthesiologist? Nobody asks the need of the anesthesiologist, which is the most important focus, more so in the current pandemic era. So let's discuss. So what are the general anesthesia routinely used as the standard method of choice for years together. We are most comfortable with the use of general anesthesia for almost all laparoscopic surgeries, aren't we? Even myself, I have mostly never done a laparoscopic surgery and anesthesia, but that is where our comfort zone lies. But again, saying that there are lot of risks with general anesthesia, like there may be hemodynamic instability, maybe even bradycardia because of the general anesthesia, more elderly people with comorbid illnesses, with lot of comorbid illnesses. Then obviously there is a lot of ventilation perfusion mismatch which occur during laparoscopic surgery and are more pronounced with the use of the general anesthesia, and which may also cause lot of post-operative respiratory complications. Then there may be, obviously there are, it is rare, but then there are chances of air embolism. And also, as we know, in the post-operative period, risk of PONV is high, much increased for general anesthesia. So the challenges are not just the risk of general anesthesia. The challenges lie more with the patient we are dealing. A more and more elderly population, we are a lot of elderly population with the increased in the life expectancies. Next, we don't have all hospitals do not have a proper resource available like it is in the Western country. So it is we have to also look after the resources, available resources, and the best possible. And also we have to accordingly the economic part also. But the most important thing which is to be given importance is that the patient safety. Having patient safety should not be hampered at any point of time. Now, in this COVID pandemic era, dealing with lot of challenges. The challenges are coming aerosol generation procedures and may cause lot of risk to both the anesthesiologist and the surgeons, and obviously all the OT personnel present in the OT. So the most of the societies, including the NISORA, are recommending the use more and more of tendency to more and more of use of renal anesthesia, all kinds of procedures. So is this a new thing? No, it's not a new thing. Dr. Jonesco T. Yes, ma'am.
Please set your microphone. The voice is getting interrupted. Okay.
Yeah. Is it okay, ma'am?
Yeah. When you speak continuously, it gets interrupted. So just see somewhere some problem is occurring, but I think you move less. Okay.
Okay. Okay, ma'am. Okay. So this is not a new thing. In the year of 1909, already Dr. T. Jonesco had recommended the procedure of general spinal anesthesia, and he was even touted as, and he was was criticized for using this procedure. He published this article where he used punctures. He recommended two types of puncture, the upper dorsal puncture and the dorsolumbar puncture. The upper dorsal puncture was between the first and the second dorsal vertebra, and which he used for the surgeries of the head, neck, upper limbs, and the thorax. And then the next point of puncture was the dorsolumbar puncture. That was the dorsal and the first lumbar puncture. And he used it for all other surgeries, including the thorax. So after it 80-90 years to next publish a study in the year of 2003. Finally, after a lot of case reports and case series, this was the first study which was undertaken by two Egyptian doctors, and they did a feasibility study using a nitrous oxide pneumoperitoneum. So what they found that all the patients were given spinal anesthesia in the L2 and L3-4 region, and they used hyperbaric bupivacaine in the dose of 2 to 2.5 ml, that is 10 to 12 mg, in addition to an additional dose of fentanyl. And they the anesthesia required was up to T8. So they did this in only 10 patients, out of which the requirement of conversion to general anesthesia was found only in one patient. Then next, another study came up following in the next 5 years. It was published, and again it was done from a European country. And there they used a segmental thoracic combined spinal epidural at T10 level, and the drugs used, they used a isobaric kind of anesthesia. So they used a lower volume of the dose because they used a thoracic spinal anesthesia mixed with additional sufentanil as an adjuvant. And the extent of spinal blockade was found to be from T3 to L3, and that was achieved within 15 minutes of injection. And the hemodynamic stability was well maintained. There was no nausea, vomiting intraoperatively, and there was no respiratory depression. All perioperative shoulder pain was a problem in 20% of patients, but they managed it with a dose of IV fentanyl. And there was no requirement of conversion to general anesthesia. This was a big retrospective study which was done by Dr. Rajiv Sinha from our country, and it was published in the year 2009. And this is a huge data of some 3,490 patients. And here they did a lumbar puncture at L1-2 level, and they also used isobaric bupivacaine 3 to 4 ml with clonidine as the adjuvant. And they did a head down tilt position for 10 to 15 minutes. So here, as you can see in the table, the general anesthesia group had a lot of post-operative complications, like the PONV was too high, the requirement of the post-operative analgesics was also high, and but the urinary retention was quite significantly higher as expected in the neuraxial anesthesia group. And there is a 20% incidence, so there's a huge data, but there is only 20% incidence of hypotension. But all of those patients were managed with ephedrine boluses. So conversion to GA were required in only 0.5%, as you can see. So various techniques which we just covered where the target should be achieved from T3 to L3 level. The various techniques of anesthesia which can be used are the segmental spinal anesthesia, and either we can use a low dose hyperbaric bupivacaine to go from 1 to 2 ml or 3 to 4 ml of isobaric bupivacaine, or we could use a continuous spinal anesthesia, or we can use a combined spinal epidural. These are the various anesthetic techniques which have been described in the literature. Now, so why do we use this thoracic spinal anesthesia has been used? Because this is when it is compared with the lumbar spinal anesthesia, this is more targeted at the site of surgery, at the site of the dose required for the spinal anesthesia the dose required is quite less. So obviously, and the thoracic spinal roots are also much thinner, so they are easily blocked by lower dose of anesthesia. So there is much more hemodynamic stability and lesser amount of motor blockade. So operative recoveries are also faster. Now, are there any modifications of the technique in the laparoscopic surgery? Not much, other than that the authors recommend a lower inflation pressures of 8 to 10 millimeter of mercury, and the inflation rate should be low. So what are the actual advantages? I'm not talking about the regular benefits of the neuraxial anesthesia, which we already know, the airway instrumentation and the venous thromboembolism and better immune function. Other than that, there is intraoperative maintenance of spontaneous respiration is well maintained, and post-operative pulmonary complications are avoided, which may not be of much benefit in a patient with normal pulmonary function, but may be of a benefit in patients with COPD or with a bad chest, you can say. And then better analgesia, definitely the post-operative analgesia requirements are also lesser, and the patient satisfaction scores are also better as per the literature. Lesser PONV, yeah, because We have not used any of the general anesthesia drugs, so lesser PONV is an obviously an expected advantage, and because of which a lesser hospital stay. Many of the studies have discharged their patient on the same day, so which will also bear on the economic cost for the patient and the hospital. But there are, again, I will not say that this is a perfect technique. Obviously, it has its own cons. So most common problem which is reported, like I already discussed, is the shoulder tip pain, which is usually caused by the excursion of the diaphragm due to inflation of the pneumoperitoneum and the irritation of the diaphragm. More so in the laparoscopic gynecological procedures where the head is low and the irritation is much more as compared to the other laparoscopic abdominal procedures. Then there is hypotension, which is obviously expected because of the, I will discuss on it. Then post-operative urinary retention and neurological sequelae. Neurological sequelae also we'll discuss. So hypotension in spinal anesthesia is not a new thing. So it is also expected here, but here it may be slightly more as compared to what we do, because there is an extra blockade of the sympathetic afferents from the T1 to T4, and also because of the effects of the pneumoperitoneum, that it may be exaggerated. But the good thing is that it was reported as an incidence, like I already discussed, as an incidence of 20.5%, but all were corrected by fluid and ephedrine boluses, and none of them required any intraoperative continuous infusion of vasopressors or conversion to general anesthesia because of hemodynamic instability or because of bradycardia. So how can we minimize the hemodynamic instability? So first thing is preloading, or like we can say the most talked about is the co-loading with the fluids. Colloids are preferably more than the colloid. The use of sympathomimetic agents, most commonly the ephedrine we can use. The use of thoracic segmental anesthesia, like I already said, the lesser drug doses will be required because you will be giving anesthesia just at the site of the surgery done, and also the thoracic spinal roots are quite, so the sensitivity is much higher. So you need to give only less drug doses. So there will be less blockade of the less peripheral of. And again, use of combined spinal epidural technique is also recommended because it will allow a slower onset and obviously a more graded approach. So it will allow a more stable hemodynamics. And then again, the use of isobaric or the hypobaric anesthesia. This is little controversial, but theory, most of the studies say that baricity, if you're using isobaric or a hypobaric solution, so that is a more or less like the CSF. So the spread is much lesser as compared to a hyperbaric solution. And also because of the use of the if you're giving the drug in the lumbar space, the spread of the hyperbaric drugs is because of the squeeze action of the lumbar lordosis, there is a splitting action. So the cranial spread and the caudate spread of the hyperbaric bupivacaine is higher. So the that's why the use of the isobaric and hyperbaric techniques are much more safer if you're using in the thoracic spinal. So next important topic is the thoracic spinal safe neurologically. So they have done a retrospective study in 113 thoracic epidural blocks in anesthetized patient, and they saw 4.4 occurrence of accidental puncture of the dura mater, but none of them had any long-term neurological sequelae. So after this retrospective study, this gentleman, Dr. Imbeloni, he did an anatomical study of the thoracic spinal canal with the MRI, and what was the distance of the skin to the spinal cord at the level of the sagittal distance from the skin to the spinal cord, to the posterior surface of the spinal cord at the level of T2, T5 and T10. So these are the three levels which he studied. And what he found was that the mean distance was quite higher in the fifth thoracic level, as you can see, and it is much more higher if it is in an angle, like we usually insert it for a thoracic spinal or a thoracic epidural. So you can see it is 45 millimeter as compared to thoracic is 9 mm and it is 9.5 mm in case of 10th thoracic. So it is quite higher. So this study demonstrated that there is a great distance from the dura mater to the spinal cord at the T2, T5 and T10 with the greatest distance at T5. So main finding of this study was that if you use a 45-degree angle when accessing the mid-thoracic epidural space, it will help protect the spinal cord as it will increase the distance and the trauma to the spinal cord will be much less. Now, there are certain meta-analysis which have evaluated the spinal anesthesia versus the general anesthesia. This one recently published in 2015 in BMC Anesthesiologist, where they have identified some 7 RCTs. They have excluded the non-randomized ones and they have excluded all cohort studies and retrospective ones. And they have analyzed more than 700, 800 patients. Their primary outcome was to see the post-operative pain, and the secondary outcome was the post-operative outcome and the operative time. So what they found that the pain relief was much better and the VAS scores were much lesser in the spinal anesthesia groups, obviously. And this is the forest plot for the primary outcome, that is a post-operative pain score, which again favors the spinal anesthesia. And this is a forest plot for the post-operative morbidity and favors spinal anesthesia. So this is another meta-analysis which they have published in 2017. It is done in around 900 patients. So this is much bigger, and this is by Longo et al. From Brazil. And here they have even seen that the anesthetic conversion was required in only 3.4% of cases in spite of the higher risk of the intrahypotension and bradycardia. So like we can see that this is quite a safe and feasible, both a safe and a feasible technique. So this is another study which was in patients COPD under spinal anesthesia, and here they also found that the risk of the hypercardia is much more lesser, post-operative specifically, much more lesser with the use of the spinal anesthesia as compared to general anesthesia. So many of the studies have compared the incidences of hypoxemia or hypercarbia, which is the area to be explored. One study where they have explored regarding the hypoxemia and hypercarbia mainly in the COPD patients. So to conclude, GA versus spinal anesthesia, who wins? I don't think that this should be like which is better, but like I said, that we have to modify techniques and we have to come out of our comfort zone and explore both the methods of anesthesia so as to tailor our anesthesia approach as per the patient parameters and the requirements of the surgeon and the anesthetist. And regional anesthesia is definitely a proven to be a safe and feasible alternative in laparoscopic surgeries. But in the current pandemic area, it is emphasized not only an alternative, but also can be considered as a primary mode of anesthesia. Definitely, patient safety should not be hampered at any point of time. Thank you all.
Thank you, Natasha. Thank you for that lovely presentation. And the chat box at this point of time appears to be empty. But, well, I must congratulate you, first of all. And I do agree there were some challenges in between because of the internet connectivity, but that's absolutely understandable. So you think level of patient comfort is good in laparoscopic surgeries done under spinal anesthesia?
Yes, ma'am, that is what actually the literature says.
But have they really evaluated the level of patient comfort? Because imagine someone in a Trendelenburg position or someone with a pneumoperitoneum. Because imagine our own cells when we have a little bloating, when we have had a little too much binging on the food. So we are uncomfortable. We are not comfortable.
Yes,
so
yes.
How do you take that idea? And then leaving the airway unsecured, absolutely, with the pneumoperitoneum, somehow I personally find it a little uncomfortable.
Definitely, ma'am. That's what I said, that we are more comfortable, obviously, with the general anesthesia. But then I just presented some literature evidence regarding the use of general anesthesia. uh, Recommending any method over any, even if today I would definitely go, but this is basically for areas which are actually low resourced. And in the current pandemic area, we may try, but then only with experience guidance.
Yeah, yeah. And I think it would be a greater idea to combine both. Now we have so many blocks, the QLs and the ESP and the transverse abdominis, so many of them to offer. And we've done not a very big study, nothing great, but we've been trying to do it, evaluating how the patients behave if you give even a simple tab block or something. Anyway, now I hand over the mic to Dr. Kalyani Bala to conclude the session. Over to Dr. Kalyani Bala.
Kalyani?
Is she around?
Yes, Kalyani, please unmute yourself. Kalyani is here, but she's not visible. I don't know. Kalyani?
Now everybody can unmute themselves.
So,
yes.
So till we find that.
Dr. Mandamangal, you're not audible.
Sorry. I would like to pose this question to Masham Jayashree Sood. She has immense experience of laparoscopic surgery. So what is her take on how does she rate regional anesthesia, central neuraxial blocks for laparoscopic surgery?
Thanks a lot. I'm sorry I missed out her lecture. The last, I had another meeting, the ICA one. But my experience and my impression of regional for laparoscopy is not there. I'm not fond of it at all. And the reason being, because GA is so safe and we have such good drugs. So I don't see any reason. But of course, I don't object to the people who are doing it. The only reason why I say it, in case, like we did have a sort of it wasn't a thesis, but a study was going on for TEP, TEP repair under epidural. Okay. And even I think combined spinal epidural, not epidural, combined spinal. And in case the surgeon pierced the pneumoperitoneum, peritoneum, and it became a carboperitoneum. Ekdam patient used to become so restless. So, I mean, it's not really worth it. So I'm not keen, although there have been so many, people are practicing it. And so also about the thoracing and things like that, why take so much risk when GA is so safe, is my feeling.
Madam, probably it is restricted to few surgeries which are going in for diagnostic procedures or something of that kind.
I think Rekha Kalyani want to say something.
Yes, yes, very much.
Am I audible? Am I audible?
Yes, audible, not visible.
Something.
Yeah.
Thanks so much, Rekha Madam, for giving me a chance to chair this session. To conclude, I want to say that traditionally GA was used for laparoscopic surgeries. Even they were telling that there was a myth that it cannot be used for upper abdominal laparoscopic surgeries. But nowadays, laparoscopic surgeries for upper abdominal surgeries are also an emerging concept nowadays in developing countries because it has an advantage of economy. Next, there is less post-operative pain. Post-operative pain management is better with regional than compared to GA. Again, there is advantages of less nausea and vomiting post-operatively. And during intraoperative period, though there is pneumoperitoneum is somewhat causes discomfort to the patient, but in these patients, they tell that the intra-abdominal pressure should be low. That is to be limited within 8 to 10. So usually the duration of surgery is somehow prolonged due to low intra-abdominal pressure. The surgeon gets some discomfort, but the patient discomfort is less by minimizing the intra-abdominal pressure. Again, another issue was that during regional anesthesia, there was higher sensory block was needed so that higher degree of hypertension is encountered in these patients. But these hypertension studies are showing that these hypertensions are well managed by vasopressors. Vasopressor agents can well manage this hypertension. And again, the shoulder tip pain was also a concern. which can be managed by shoulder tip pain can be managed by intraperitoneal instillation of local anesthetics and also by giving intraoperative opioids. So in regional anesthesia can be used. Nowadays, the role of regional anesthesia is not limited to comorbid conditions, but to combine both in cases where there is comorbidities and there is a contraindication for GA. In those cases, we can go safely with regional anesthesia.
Okay.
There can be, it can be actually a big debates, but I won't because I think the time to conclude.
No, madam, but all said and done, you're right, madam. The take-home message cannot be on the other side also.
Absolutely.
And Dr. Nimisha was very honest in her opening remark that she has in her life throughout given GA, and this is all based on the literature.
Yeah.
And there was some comment of economy. When you're doing laparoscopic surgery, economy goes out. And secondly, low resource settings. If you're doing laparoscopy, then also the low resource settings goes out. But yes, it is a fact that in majority of the institutes, Madam Sood will agree, GA is the
standard
only thing which is offered. Only for research purposes, some regional anesthesia technique is spinal is offered. But yes, in many our private practitioner friends are doing it over the years successfully. But that has to be reported also, so that others can also learn from their experiences. So I agree with Madam. Our experience is more with general anesthesia as far as laparoscopic surgery.
Can I just add a sentence to this, Dr. Naveen?
Yes, sir, please.
Yes.
See, if at all you are doing a regional, make nasal capnometry as a mandatory tool because you want to numb the shoulder tip pain with intrathecal, intravenous opioids or intravenous ketamine and all those things. And hypoventilation can be very, very easily go unrecognized, and you may end up with airway disaster. So nasal capnometry is mandatory if at all you're doing in the regional. It's very, very important. Of course, I also don't do regional for laparoscopies, but GA is anytime safer and safer.
Yes, thank you, sir. Because postgraduates are also listening to these, so we should not. We have to give them a good message to them that GA is a safer option. Because as you rightly said, if you end up giving so many drugs, Fortwin, Finargan, ketamine, midazolam, and the only thing which is left is put a trickle tube. So, but still, there must be many friends in our audience who had very good experience. So, but for the postgraduates, it's the GA which is the safest one.
General anesthesia with controlled ventilation.
Yes, I think Dr. Naveen, always the general anesthesia is a gold standard.
Yes, ma'am.
Okay, sir. Can we come to the end of this session? I thank all the speakers and all the chairpersons and even the audience at large for the viewing. So many people were there. Naturally, we have gone out of time, so many have logged out. And at the end, I must thank our encouraging national president, our secretary, and all the EC members, senior members.
Yeah, they are. You invite them for a few brief comments. Dr. Tejpal sir is here.
Yes, where is
and
sir?
Dr.
I would request Tejpal sir to speak a few words. He's always
Dr. Mayank is there.
Thank you, madam. Thank you, Dr. Naveen. All speakers were excellent. RSSCP is doing a commendable job by organizing these webinars. They are very informative. Dr. Naveen and the hosts I have noticed have always taken all care to ensure that the speakers are of great metal. And every speaker is proving his worth. And I have always enjoyed the lectures. Best wishes for the organizers and thanks to everyone whosoever has worked hard to see that this webinar is very successful, which it really is. God bless you all. Long live RSSCP. Thank you very much.
Thank you, sir. Thank you. We've got senior members. Dr. Chitora sir is there with us. A few comments from him. And then I'll come to Dr. Vijay Lakshmi, Dr. Rakesh Garg, and Dr. Rakhi Goel. You can unmute yourself, Dr. Vijay Lakshmi.
Very informative sessions. Today we had excellent talks to start off with, and I had to personally message them. So good, really enjoyed. I think we'll keep going this way, and I mean, I for real, I'm not missing any CMEs or anything live because the webinars are going really great. So long live RSCCP.
And you can invite for the 16th webinar also, Vijay Lakshmi.
Yes. December 16, 6 to 8 p.m. Again, we'll be hosting RSSP Puducherry. We'll be having an interesting session once again. So I invite you, all of you, to join us on that day again, and keep joining us every second weeks, Wednesdays. So this will go on for some time. Thank you.
Dr. Rakesh Garg, and then I'll come to Dr. Aki Goel.
I think today's session were excellent. A lot of key messages and carry home messages. All speakers were wonderful. I think kudos to the team for wonderful sessions, and our strength is increasing with every session. So this means the academic level is going high and high. So all cheers to the RSSCP team and all the organizers who are doing wonderful job for spreading the academic work to everybody. And congratulations once again for wonderful sessions.
Thank you, Dr. Rakesh. Dr. Aki Goel.
I must thank all the speakers and the organizers, more importantly, for drawing such good audiences. In today's time, when there's so many online sessions going on, if 200 people attend each time, it speaks of the high quality of talks that RSACP is able to deliver. Last few times, I thought this is the best webinar I have attended, and then the next one comes out to be even better. I don't know where it's going to stop, and I hope it doesn't stop. And we continue bettering ourselves with every Wednesday to come. I think really we should say 3 cheers to RSACP. From my side, and for all the organizers, the president, the secretary, and everyone who puts in so much of effort. Thank you so much.
If any other comments from anybody else, Chandrakant Patel, I can see him, our ex-GC member from Mumbai, or Dr. Chitora, sir. Chandrakant, are you there?
Sir, good evening, sir. Good evening, everybody. I am sorry for joining late because of some prior commitments, sir. Last 2 lectures I could attend and heard the expert opinion, seniors' opinion, sir. So I enjoyed this, and this very pertinent this topic was, and the speakers were excellent, sir, and the postgraduates will be benefited very much, sir. Thank you, Dr. Naveen, sir.
Thank you, Dr. Chandrakant. And before I finally hand over to Dr. Rekha Das, if anybody else wants to make a comment, he or she is most welcome.
I would want Dr. Mahendra Kamdar to say something about regional anesthesia for laparoscopy.
Sir, please.
Your experience, because he is a 100% private practitioner. So you would like to hear from the god of private practice.
Can you hear?
Yes, madam. Yes, sir. Yes, sir.
Can you hear me, please?
Yes, sir. Yes, sir.
Can you hear me?
Yes. Yes.
Okay. See, I've been listening since the beginning. I have 2-3 comments to be made. One is for Dr. Indrani. I had already heard your talk in one of the conferences about these herbal medicines and all. Since then, I've been always asking pre-operatively to my patients whether they are taking any of the medicine that I don't know. And so many times they tell, but unfortunately, I really don't know what these medicines are. So I cannot take any decision. So as you rightly said, I just go and treat the symptomatically those patients. And
Sir, you are not audible.
No, some internet
There
issues.
is some problem. There is some problem with the audio.
Internet issues are there.
You can wind up.
Dr. S.P. Sharma sir, over to you, and then over to Dr. Rekha Das. Final comments from your side, Dr. S.P. Sharma sir.
Yes, it's a definitely a great, excellent webinar. Or in fact, it's giving great pleasure that things are moving forward and periodically. This is a regularly organizing. This is something very great. Number two, today's webinar was really very excellent. All speakers spoke well, and that too, the discussion was also very good. This is a very important part, and in every lecture you got something new in the sense that which can be useful in practically also. That's a very important. So I really congratulate Dr. Rekha Das and her team, and I just thank to all my these colleagues as well as all participants, and I hope the things will continue in future also. Thank you very much.
Thank you, sir. So we have kept our tradition of finishing the webinars at around 9 or post 9. So, so it's 9 o'clock. Over to Dr. Rekha Das for wind up, because we never finish at 8 p.m. We always go past 9. So final comments from your side and vote of thanks. Right. Over to you.
My apology for not sticking to time, but the experience that was shared by all the speakers was so beautiful, and it was so personal experience that they were shared, and it was their experience that I never wanted to interrupt in between. So I'm sorry that we are running out of time even. So I'd like to conclude this. I would once again thank all the speakers for the wonderful presentation they made today, and all the chairpersons for sparing their valuable time also, and all the audience. But last and not the least, all our patrons, our national president, secretary, and all the senior members present here. Thank you once again. And with this, we come to the end of the sessions.
Thank you very much. Long live RSSP. Good night.
Thanks a lot. Thank you. Good night.
Long live RSSP.
Good night.
Thank you, madam.
Bye-bye, sir.
Thank you. Bye-bye. Good night.
Good night.
Good night, madam. Good night, everybody.
Good night, everyone. Good night.